Well, Metin Dar, good morning, everyone, and welcome to this meeting in public of the Board of the Royal Cornwall Hospitals NHS Trust on an important day for the NHS when the Prime Minister is launching the new 10-year plan for the National Health Service, and more of that anon under the Chief Executive's report. Can I welcome everyone who's gathered here in Truro, but also everyone who's joining us online. We normally get about 50 members of the public or members of staff, as well as board members who are joining us online, and obviously you're all very welcome. Can I also remind everyone that the meeting is live streamed and a recording of the meeting will be placed on the Trust's YouTube channel. And just a reminder for members of the public that Teams Live has a feature of live subtitles if you need them, and they can be accessed by clicking on the screen. Just a few bits of etiquette before we get going. Can I just emphasise to all speakers introducing reports that we've got a very tight timetable today, and if introducers speak too long, then we'll get timed out. So we all have read all the reports, so could we keep the introductions to key points only, or anything that's changed since the report is written, and not more than 2 minutes for introductions, please. The usual plea, which is always ignored, to avoid the use of acronyms, but if we can, there'll be people watching who don't understand all these acronyms. I've been told that there may be a test fire alarm drill, but that it will be a test. But obviously, in the event that there's a real fire alarm, we will have to vacate the building, those of us who are here in Truro, and gather in the car park. In relation to members of the public who are watching, if you have any questions, they're very welcome. But could you please use the Q&A function, I should say question and answer, having spoken about acronyms, shouldn't I, on Microsoft Teams, and that these will be reviewed by the Company Secretary as per the protocol that's set out on the agenda. Questions will be asked at item 24, and we've allocated up to 15 minutes for that particular item. The Company Secretary will ask the question on your behalf, and then you will seek a response, or she will seek a response on your behalf from the relevant director present, or arrange for a written response to be included in the minutes. We'll have a break here at about 11 o'clock for 10 minutes, in accordance with good practice, and the meeting in public should conclude at around 12:30. But obviously I'm reliant on board members to achieve that outcome. Apologies for absence. I don't think we have any apologies from board members or from those in attendance, Lindsay. And we will have some people attending for timed business. John Clegg, Transformation Manager in the Women's and Children's Care Group, will be joining us for item 5, the board story, and Joe Burton, the FTSE Guardian, will be joining us for that particular item. And having said FTSE, I should say freedom to speak. So it's 10p in the jar for anyone who uses an acronym, and I've already 20 minutes down. Anything else from the items, Lindsay? So item 2 is declaration of board member interests relevant to the meeting agenda. Does anybody have any interests to declare, please? Okay, thank you. Item 3 is the minutes of our previous public board meeting, which was held on the 1st of May. Can I ask you to confirm those minutes for accuracy and approve them, please? Robin.
On page 2 of the minutes, section B from the patient story, I took the patient story to operational leadership group, not the executive leadership team. Thank you.
Any other corrections? Not subject to Robin Jones, the Chief Operating Officer's comment. Can we approve the minutes? Thank you. It takes us on then to item 4, matters arising, the action log, which you have in your pack. Does anyone have any questions in relation to matters arising and particularly in relation to the action log. Kim?
Yes, action log 24/25/182. I'll just liaise with Sue. I did give an update at the previous board, but it's not reflected here, which should potentially then complete that. But I'll just touch base and make sure that that's updated. I apologise.
Thank you, Kim. Okay. And I have some hands up on screen. First of all, Alison Thorne Henderson, our Chief People Officer.
Thank you. 24/25.167.
You might be muted, I think, Alison.
I shouldn't be. Can you not hear me? Can you not
Sorry,
hear me?
Alison, we're just sorting it out here in the room.
I can hear you.
Okay.
Thank you, Alison. We can hear you.
Thank you. So 24/25.167, we did provide an update. Possibly it was after the cut-off, so apologies if it was. Unfortunately, the national team for EDI does not collate comparative data for EDS, so we're not able to complete that action.
Thank you, Alison. And then can I go to Richard Kramer, Non-Executive Director?
Good morning. My query actually might be in relation to what Kim was about to say, but didn't complete. It's regarding the new guiding principles for learning disability and autism. I have raised this previously at board. Actually, this is an action from December 2023. So it really isn't acceptable to wait so long for guiding principles to support disabled patients. This is really an ICB matter, but obviously has a wider implication from us. So I would really like to hear the update, given the matter's been outstanding since last December. Well, December 23.
Thank you, Richard. Good challenge. Would Steve or Kim like to comment?
Yeah, Richard, I'll make sure that that's, I'm just trying to find it now as we speak, so I'll make sure that that's updated and that you're kept informed. And you're absolutely right, it is a system-wide one that we have been challenging, but I believe it had now been resolved, so I'll just find it and make sure it's circulated.
Thank you, Richard. Thank you, Kim. And Ian Dean, Chief Finance Officer.
Yeah, thank you, Chair. Just in relation to action 2526.27, just to update board that Isabel and I met earlier this week and had a good conversation with some feedback on those aspects. So I think that action can be closed now if Isabel's happy with that as well.
Thank you. Are there any issues that you wanted to raise on the action log, Lindsay?
Thank you.
Thank you. Just looking around just to check if there are any more. If not, then could we keep moving and go on to item 5, the board story? And could I ask Kim O'Keefe, Deputy Chief Executive and Dual Chief Nursing Officer, to introduce this item, please?
Thank you, Chair. I'm sure we're all aware that on the 28th of June, it was Veterans Awareness Day, and I believe we've got John Clegg with us today that will be available to answer any questions. And whilst it was on the 28th of June, I thought it would be really, really appropriate as a board if we listened to one of our veterans' stories. So if we could play the video, please, Pete.
I served in the Royal Navy for 32 years. I joined as a radar operator and served on many ships. I was on HMS Exeter during the Falklands campaign, and I served on HMS Ark Royal and HMS Illustrious, and was involved with the Bosnia War and also the Gulf conflict as well. I was previously diagnosed with osteoarthritis of both hips quite severely, but at the time I sort of parked it because my wife then was diagnosed with breast cancer. So I focused all my attention on her. And when she passed away, I realised that I couldn't really live in Southampton anymore, so I moved down to Cornwall, and I then registered with my local GP, explained the situation, and he referred me to the consultant, and he knew straight away that I was a veteran. He sort of prioritised me a little bit just because I was in a lot of pain and I could virtually not walk. So he, as soon as he referred me, he said, well, I'll get you in, I'll do your left hip first, and a few months later do the right hip. And that's exactly what happened. And it was all so smooth. It's just transformed my life, basically, having had the 2 operations. And, you know, I think the fact that he actually recognised I was a veteran and used that to boost me up the list, if you like, I think, yeah, it boosted my confidence and morale no end. What helped me throughout the whole of the process was the fact that everything was explained to me. I knew exactly where I had to be, what I needed to do, all the preparations I needed to do, which actually was quite daunting, because when you live on your own, I thought, well, how am I going to do this, and how am I going to do it? It raised a few questions in my mind, but I got my daughter and various other people to sort of assist post operation. But actually, within about a week, less than a week, I was quite sort of mobile and able to sort of fend for myself. So the best part of the process was getting everything explained to me, knowing where I needed to be, what I needed to do, and what I needed to do to prepare. And I had all that information. Once I had all that information, I just got into my military mode and put everything in place and planned it, and it worked very well. The physical side of it was me jumping on a bike and doing more exercise. I obviously walk the dogs as well. I've got 3 dogs, so that's quite an intense physical activity in itself. And yeah, just going across to doing National Coast Watch and another voluntary work that I do in Cornwall has been, you know, it's helped the repair process, if you like, both mentally and physically. As I said, the consultant was instantly aware, but when I went to the doctors and registered, I had to tell them that I was a veteran. But when I went to the doctors and registered, I had to tell them that I was a veteran. You are, shall I say, acknowledged initially as a veteran. But I put that 2 ways, because some veterans don't tell people that they're veterans. Me, I say I'm a veteran, because I know, you know, lots of people do lots of great things, great jobs in that. But when you've been a serviceman and you've been in action, you know, actually fought for your life and fought for your country, you have a different aspects on life. You've gone through different life experiences to what most people have gone through. And so I think veterans should be treated slightly differently. And I think some of the you know, from a medical point of view, they should be prioritized, because, you know, I see a lot of ex-military people limping along and, you know, wheelchairs, walking sticks, and in fact, there's a gentleman that's at our local community centre. I found out he was an ex-chief in the Royal Navy, and he's got bad knees. And I said to him, does your doctor know you're a veteran? And he went, no. So I haven't told it. I said, you need to tell them, because you get registered on your documentation. So, and I think if people from the NHS can be made aware and are aware and probably try to understand what a veteran really is like, and both mentally and physically, because there are lots of us with mental scars as well as physical scars. So
Thank you to Mark for sharing his story. Before I go on any further, John, would you like to say anything as regards RCHT's commitment to the Veterans Covenant?
Yes, thanks, Kim. Hopefully you can hear me. And
Yes.
thank you very much for having me this morning. Good morning. And thanks to the comms team and to Chris Hocking and Patient Experience who pulled that together. I met Mark at a veterans breakfast that RCHT put on back in March. And there were about 30 veterans, some from the hospital, some employees of the hospital, mostly people who live in Cornwall, and all of them who'd been in the hospital had positive experiences. So that's a great thing to take back. So RCHT has a very close relationship with the armed forces. We've got the helicopter base down at Culdrose near Helston, which is the largest helicopter base in Europe with over 3,000 personnel. We've also got RAF St Morgan and 250 personnel, and Europe's largest naval base in Devonport in Plymouth, just over the water in Devon. And all of those personnel have got families associated with them. A lot of people live down in Cornwall. And across Cornwall, there's the Office of National Statistics estimates around 30,000 veterans living in our community, which is around about twice as many as the national average. And whilst some of them served in the national service, so anybody who's over the age of about 85 will have done, in male over the age of 85 will have done national service. There's also a significant number of people who served in the 60s, 70s, 80s and 90s when the armed forces were much larger. I run the Armed Forces Network for the Trust. There's twofold. Firstly, supporting patients in the hospital. So we actually have a veteran in the hospital at the moment who we are supporting under the Armed Forces Covenant. And the Trust re-signed the pledge to that in October last year. And we also are very closely linked with the Veterans Covenant Health Alliance. There's training. There's likely to be additional training coming for NHS personnel. That was announced by the government last week. And there's also a requirement, or likely to be a requirement, for us to respond as to how many patients we have in the hospital from the armed forces community. At the moment, that's recorded in PAS, which is rather clunky. It's been highlighted to eCare, and as we get that system next year, it should become easier for staff to ask patients if they're part of the armed forces community and for us to record it. We also provide support to the staff in the hospital. There are over 100 veterans working in our staff and about 40 spouses. It's probably far greater numbers than that, but that's who've identified as that. We received the Gold Award for the Defence Employer Recognition Scheme earlier this year, and the values of the armed forces align very closely to the NHS, so it makes it easy for people to transfer if they are leaving the service. We've done a few initiatives such as a work placement. We've done some help to people who are thinking of leaving, just talking to them. We also facilitate flexible working to enable childcare. So we're actually doing stuff. It's not just a gold award sitting on the back of people's Teams channels. And both elements are interlinked. We just need to be better at asking people if they are part of the armed forces community, providing the right environment for them while they're in the hospital, and then reaching out to the Ministry of Defence, the NHS elements, and the third sector, who can provide support, whether it be housing or equipment, to allow people to recover either in a care home or back at their own home when they finish their treatment at RCHT. So thank you very much for watching the video and for your time this morning. If anyone has questions, I'm very happy to take them.
Service, and thank Mark for his service as well. Steve.
Yeah, thank you. I'd echo that. John, thank you for your leadership. You've mentioned the Armed Forces Covenant and the Gold Employer Recognition Scheme. I would just want to recognise your support and your leadership in helping steer us through to secure those that commitment, that support, and the steps that are behind that. We're very grateful for that. My question is there anything more the board can do, or that we could ask the wider organisation do, to increase awareness of veterans and their unique position, and anything more we can do to support them?
So the biggest thing we can do is to ask people if they've ever served, or a family member ever served in His Majesty's Armed Forces, and to record that. And then as eCare comes online, that should be flagged up. And then that means that the nursing staff in particular can make sure people are looked after in the hospital. People who have PTSD often suffer from noise and light. That's not everybody, but making sure people are cared for, and then accessing the support that's out there to assist people to move on, recover at home or in a care home or another suitable environment. So asking the question is the biggest thing that people can do. And if I could ask the board's support in that, that would be really useful. Thank you.
Thank you.
Thank you, John. Can we move on now to Richard Kramer, please?
Thanks, David. That was an incredible beneficiary story, and very impressed, John, by your leadership and commitment, which is very apparent. My question was, listening closely to the story, we heard not just about physical scars, but mental scars. So I just wanted to understand how we provide that wider support for someone's mental health needs, and maybe associated benefits or financial support as well.
So the NHS and Ministry of Defence have 3 or 4 different elements. They're now rebanded under operational names, so they're called Op Courage is the mental health support. So if you see Op Courage, and we're about to refresh the posters around the hospital, Op Courage provides armed forces community with mental health support. RCHT has limited mental health support within the hospital. We do have some people who work within the trust. Most of the mental health support in Cornwall is provided in the community by CFT. So our staff in the hospital have been briefed. We had a lady from called Michelle who came down from Dorset to talk to the emergency department recently, and the mental health support team to be able to signpost people down that route to Op Courage. The other elements are Op Restore, so that provides physical health support and well-being. Op Fortitude, which is housing support, so a disproportionate number of veterans end up homeless for various reasons. Fortitude can provide support with that. And then there's Op Nova, which provides support for those in the justice system. So there's a number of different elements out there. We'll get the posters refreshed over the next couple of months. And if anyone ever comes across somebody who needs some support, there's information on the RCHT website at the moment, and they're welcome to reach out to the network and we can point them in the right direction. Thank you, Richard.
Thank you, John. Now could we move on to Alison Thorne-Henderson, please?
Yeah, I won't reiterate a lot of what Steve covered, but just wanted to thank you again, John, for raising awareness around patient mental and physical issues. And to say the film was a really good illustration of that. I spent last Saturday with veterans and really understand the point that was made around the values and how the values, the CEDRIL values from the military, link with RCHT's values, in particular respect. Also really appreciate the transferable skills that military staff can offer us. And I suppose in sort of building that question that Steve posed, I think we need to look at more ways that we encourage staff, and we're going to see this later on in our board meeting, to declare on ESR, you know, their background, including military experience, but also, you know, it's when you walk into the emergency department or you go for your outpatients appointments, the points that you've made, that people are able to make that declaration straight away. So thank you very much for everything that you do.
Could I just build on that, Alison? Your team have been really supportive to me, and there's items such as Step Into Health, Forces Family Jobs, which is for partners of service personnel. We're signed up to those. Appreciate the recruitment at the moment is quite a challenging position for the trust, but we have done that and we will do that again once our position improves. So thank you, Alison.
Time on this item now. Could I just hand back to you, Kim, for any closing remarks?
So, John, just to reiterate the board's thanks for your leadership, and please take us up on Steve's offer of anything else we can do. It's really, really important that we're able to highlight and pay respect for people's service, but make sure that they're able to easily identify and be signposted to access the services we provide. Thank you.
Thank you.
Thanks to you, John, and thanks to Mark. And the last quarter of an hour has been all part of raising the awareness that Steve has talked about. So thank you very much. Any other comments, or can we move on? So with renewed thanks, could we move on then to my report, which is there for you to see, so I won't introduce it. Just a couple of updates on my walkarounds, which I mentioned. After the board meetings today, and a meeting on the NHS plan that Steve and I have to go to. I'm going to have the pleasure of doing a shift in the emergency department with Dr. Toby Slade, who came to talk to the board about urgent and emergency care about a month ago or a few weeks ago. I'm not sure that Dr. Slade requires my support, but he's very kindly offered to let me shadow him because I would like to see what the ED is like during a busy period when all the ambulances are coming in. And I'm sure I'll be able to share my learning with you after that experience this evening. We have congratulated him in private, but this is the first opportunity in public we've had to congratulate Richard Kramer on the award of an OBE and the King's Birthday Honours List for services to people with disabilities. So could I just ask you to thank him in the usual way, please? Congratulations, Richard. On the next director, we are now interviewing. We're interviewing 3 candidates tomorrow, and I'm being supported by the Vice Chair, Isabel Down, and Non-Executive Director, Uzma Bozai, who was herself an ex-director and is now a full voting Non-Executive Director. So we're interviewing tomorrow, and I hope we have a successful outcome. And it's also mentioned in my report that I was planning to meet the new Bishop of Truro, Bishop David Williams, which I've now done. We had a very pleasant hour together at his residence at Liz Escop, and the Bishop is very seized of health inequalities in Cornwall and wants to do whatever he can to help change that, and obviously is very committed to the chaplaincy and hopes to visit the Royal Cornwall hospitals as soon as his schedule allows. So I just thought I would report on that meeting, and I'm sure we all wish Bishop David well in his ministry. So that's everything from me. Any questions or comments? If not, could we move on to a very comprehensive and transparent Chief Executive's report? So thank you for that, Steve. I'll hand over to you.
Yeah, thank you, David. So I'll take the report as read. Just draw out 3 or 4 particular points for us to be mindful of. First one is the National Urgent Emergency Care Plan has been published. The details are set out in the report, but just to particularly draw board's attention to the very clear improvements required nationally, improving Category 2 ambulance response times to better than 30 minutes, delivering a maximum ambulance handover wait of 45 minutes, and to reduce the number and proportion of patients who wait in the emergency department for more than 12 hours, particularly stand out in that. And of course, all 3 of those are part of our focus within our internal action plans. So I won't say anything more about that other than recognise its importance. Colleagues will also see the information about the National Pay Awards, the Secretary of State supporting the Independent Pay and Review Body's recommendations for pay awards, 3.6% to Agenda for Change staff, 5.4% for resident doctors, and 4.0% for consultants. And those pay awards are being implemented nationally, backdated to the start of April, and I understand they'll be paid in the August pay in line with national requirements. There is a full update on the Women and Children's Hospital, so colleagues will see the update there, particularly including the identification of a new preferred way forward location. So that location remains on the Royal Cornwall Hospital site, but that new location would enable the project to progress more quickly, and that's particularly important to us given the financial allocations by government require main construction to start in 27-28, and that new preferred location would allow that to happen and also de-risk some other aspects of the programme. There is a comprehensive update on urgent and emergency care performance, both in my report, David, but of course we have a substantial item on urgent and emergency care performance as well. I think that's absolutely appropriate given the imperative for us to make further, faster improvements on urgent and emergency care. What I would say is our colleagues across the organisation are working incredibly hard to identify those opportunities where we can make further progress, and I'm sure you'll see some of that when you have your walk around with or your shift with Toby Slade later on today. Two things to celebrate. The first one is the Commercial Research Delivery Centre. That's noted in your report as well, David, but it was fantastic to be able to join colleagues in celebrating the formal opening of that in early June. Just to recognise the award there of £3.5 million of National Institute for Health and Care research funding is really significant. We were the only commercial research delivery centre in the entire Southwest region, and when we look at the other organisations that were successful, they tend to be much larger organisations. So it's a great reflection of the passion and the expertise we have in research in this hospital, in our trust, but also across Cornwall. And the other thing to celebrate is the opening of the West Cornwall Hospital Outpatient Department. That's been in construction, as you see, for almost 18 months. And I had the opportunity to join colleagues in the first couple of weeks of that new facility being opened to see it, and it is fantastic. We already had a great outpatient team there, and what we now have is a fantastic environment and facility for staff and patients there. The final thing I want to comment on is the NHS 10-year plan. We are expecting the 10-year plan to be published today. And we understand that that plan will focus very, very significantly on the three key themes that the Secretary of State and the Prime Minister had already set out. Those three themes being a transfer of services from hospital to community, wherever possible, a transformation of services from analogue to digital, and a shift in focus from managing ill health to supporting prevention and improving health outcomes. We are expecting, when that plan is published, to see a significant focus, particularly in that first theme of hospital to community, around the development of integrated neighbourhood teams and improving and strengthening resilience of services in the community to support patients in the community and therefore to avoid emergency admission or readmission. And we're also expecting to see significant ambitions of improving access year by year in the NHS into the full range of health services and setting out that 10-year transformation programme. So I think we'd be intending to bring that back to the board at the first opportunity after that has been published, but we expect that to be published today, and that will be particularly important for us to test our refresh of our strategy against that 10-year plan once we see that. But happy to take any questions on the rest of the report.
Thank you very much, Steve. Questions or comments for Steve, please? Ian.
Thank you, Steve. Really comprehensive report, as ever. Just one thing I wanted to clarify in section 6, the job evaluation update. My assumption is that that will be tracked through People and Culture Committee, but just to be clear on that, because it'd be useful to get updates through that committee going forward. And my second one was just a comment you captured in the report about the celebration of National Estates and Facilities Day. I had the pleasure of doing a domestic shift for an hour that day. It was hard work. I think it just really brought to focus me the importance of that team and colleagues in that area for keeping patient care to the standard we see every day. So it was a really good experience, and thank you for capturing that in your report.
Thank you.
Thank you, Ian. That on that last point particularly, that is really important, and the number of examples we've seen about the direct impact and contribution our supporting service colleagues deliver to how we deliver care is incredible. So fantastic to have that opportunity to celebrate. And on the first point, yes, absolutely right. We'd expect the progress of that to be tracked through our People and Culture Committee and onto board as and when required.
Thank you, Steve. Uzma Bozai, Non-Executive Director. Uzma.
Thank you. Just wanted to pick up on point 5 in your report, Steve, about the switch that our hospitals have made to decaffeinated drinks. I thought it was a great example of what seemingly small innovations and the impact that they can have, 30 to 35% reduction in falls actually makes a big difference to patient safety. And so it would be great for that to maybe be widely shared so that members of our community can maybe make similar changes and prevent falls. But I thought that was great innovation.
Richard.
Yeah, I just wanted to say thank you to Steve under the section Stick Frail patients. I'm really delighted that patients are part of the clinical vision of flow, I think that's a really important that we embed co-design in when looking at all our care pathways, and it'll be good to track what difference it makes in terms of changes as a result and shifts of accountability. But it was a tiny part in the report, and I just wanted to say thank you for doing this.
Thank you, Richard. And I'd want to pass my thanks to our two colleagues who've been working with us in some very, very challenged discussions and areas about how we can deliver improvements. They've had a direct impact, and they've given significant time to us. So it's been really, really significant and really positive to see that.
Thank you, Richard. And now Adam Broom, Non-Executive Director. Adam.
Thank you. And it's a question for a combination of Steve and Ian, I guess. So it's item 8, the pay review you touched on, Steve. And it's referenced in the later finance reports, the potential financial consequences of the pay award. And we've budgeted for a certain percentage, and the national position is a higher percentage. Is there any indication as to whether the government will meet the difference, or if there isn't, is there an expectation that they will?
Ask Ian to comment, if that's okay, David.
Yeah, thank you, Adam. So we've had further updates actually since the papers were written. So there is now, we've had confirmation there will be an uplift to the amount of income we get through our contracts, so the contract uplift factor. So that's been confirmed as 0.67%. And that's on the entirety of our contract. So we're just working through the value we think that will be from each of our contracts across the organisation that we have. The additional cost is in the region of around 4.5 to 5 million as an impact of the pay award being higher than was set in the planning guidance. And we'll be doing a piece of work just to understand if there's any residual gap in terms of affordability between that uplift in our contract values and the outflow of expenditure we expect from the pay award. So we'll be able to report that back through Finance and Performance Committee next month, having board in private next month as well.
Can't see anybody else with a hand up. So if there are no further points to Steve, can I thank you very much for that report, Steve? And move on to item 8, urgent and emergency care. Just to remind everyone, under section A of our report, which is matters that require discussion and decision, we always have an item on urgent and emergency care, because although we have many important things we have to do, this is our overriding priority. Before I ask Robin Jones, Chief Operating Officer, to introduce the report, could I just check with you, Steve, if there's anything you wanted to say?
Only to echo what you just said about the overarching prioritisation of urgent and emergency care. I know my executive colleagues, along with our clinical and operational leaders across the organisation, are driving performance improvement opportunity across our organisation and supporting our clinical teams to make rapid transformations of the way in which we deliver services, and we'll reflect some of that approach in the update that Robin will give.
Thank you, Steve. Robin.
Thank you, David. So board colleagues would have seen quite a lot of the content of this report before. For members of the public, it was just a timing from our stock take. A stock take from our clinical vision of flow. It felt appropriate to put that information in the public domain, so that's why it looks duplicated. I will draw colleagues' attention to section 3 of the report, and in particular, the maximum or the longest ambulance holds we've had. So we have made some significant improvements on our average handovers, and we have seen improvement in our 4-hour performance. However, it can't go unnoted that we are still experiencing exceptionally long delays of ambulance handovers. We see that out of hours, so our in-hours processes are much better, and we now know that we need to focus our energies on the out-of-hour mechanisms to resolve that. You noted our patient representatives who are on the clinical vision of flow, and we need to say a big thank you to the time commitment they are giving us. They are actively engaging in a rewriting of some of our standing operating procedures on the back of conversations we had only earlier this week on further actions we need to take to accelerate our flow of patients from the emergency department through the hospital. The only thing I would then draw colleagues' attention to is the section of the report where you can see that as an executive, we have defined our shape and form of our organisation as part of making sure that we know what good looks like in terms of keeping things like our same day areas protected to be same day. That's clinically led. Our clinicians have asked for that, and those are the things that we're delivering. And that shouldn't be underestimated, the amount of work that our colleagues have put into maintaining that delivery. Thank you, David.
Thank you, Robin. Are there any comments or questions for Steve or Robin? Adrian Davis,
just
Non-Executive Director.
Yeah, sorry, Adrian Davis, Non-Executive Director. With the focus on urgent emergency care improvements, I just really wanted to seek assurance that we're also, the likelihood of industrial action, further industrial action within the NHS is growing, and just to check that we've got our business continuity plans all dusted off, updated, and incorporated the learning that we got from the last periods of industrial action.
Yes, Adrian. So we took a lot of learning from the last industrial action. We have a very robust process where everybody comes together across all the professions, and we make sure that we are covered in all regards. And we were successful in maintaining an element of elective work as well as maintaining our urgent care standards. And actually, we're booking in a session review in our general managers during this month. We could do a run through what we learned from last time with you during that session, if that would help.
Yeah, that'd be great. Thank you.
Thank you, Adrian. Could I bring in Matt Hill, Non-Executive Director? Matt.
Thank you, and thank you, Robin, for all the great work you're doing to improve the flow through the hospital. I just wonder whether there's a sense of shifts in across the system, whether they're helping to bring things down for the hospital, the ambulance waits. So yeah, just whether there's impact that we're seeing across the system.
Thank you, Matt. So we now have a daily session with our executive colleagues of Cornwall Foundation Partnership Trust, where we call it laser focused on 8 core indicators, where we're working collaboratively to support ourselves with our urgent care challenge. And also in the report, Matt, we're calling them 7 pillars, and there are 7 pillars of work that we're doing across the whole system, not just us and CFT. And we meet weekly to review those 7 pillars. That session is chaired by the Chief Operating Officer of the ICB, but also has NHS England regional representatives on that call as part of us coming together as one whole system to focus on these challenges.
Okay, just to add a little bit of detail, Matt, to give you some examples of that, those 8 metrics reviewed every day include mental health long waits in the emergency department, flow of patients by time of day from RCHT to CFT, where patients need to transfer to Cornwall Partnerships NHS Foundation Trust, and the progress we make in terms of stepping down or stepping up patients into hospital at home and virtual ward capacity. So there's a very, very strong partnership with Cornwall Partnerships NHS Foundation Trust and Royal Cornwall Hospitals NHS Trust in terms of driving those aspects forward. We do work closely, clearly with other parts of the system as well, Integrated Care Board, primary care and the local authority. And there are areas of improvement needed elsewhere in the system. One of the challenges that Cornwall Partnerships NHS Foundation Trust face is a flow out of patients out of their hospital beds into home with some form of onward care. I mention that because that has an impact on Royal Cornwall Hospitals. If there are any obstacles there, that can create a challenge in being able to transfer those patients who are ready to go from Royal Cornwall Hospitals to Cornwall Partnerships NHS Foundation Trust. So all of those areas are part of our system-wide plan.
Thank you, Steve. Thank you, Matt. Could I bring in now our Vice Chair and Chair of our Quality Assurance Committee, Isabel Down? Isabel.
Thank you, Chair. And Robin, thank you for the report and the summary. It's really helpful. I'm just picking up on Steve's point, really, and I just wonder if there's anything else that we should be doing internally to increase the level of discharge to home, so not going to CFT, but to Community Partnership Trust, but actually to home, because that has been one of the major things that I think has prevented us from clearing our front door when we're clogged up at the back door, so to speak. So just wonder what else we need to be thinking about doing to increase that level of discharge.
Started to see our number of, we call them pathway zero discharges. We've started to see those now coming towards the 80% territory, which is nationally benchmarked as the ratio that we should be delivering. We do know that the work that's concluding as we're sat around this table on our acute medical unit to be able to take our medical take up onto the acute medical unit should enable our acute medics to achieve more discharges home as well and reduce the number of patients in the emergency department. And myself, Steve, Kim and Mary have been committing to doing big conversations with our teams, facilitated by Hannah Falvey, one of our psychology colleagues, to get under the skin from our colleagues who are actually doing the job. What are the barriers that they're facing so that we can start to unlock them? They've been incredibly enlightening, Isabel, and we have a lot of work to do as a result of listening to our colleagues and picking up the themes that they are giving us for us to work our way through to support that.
Thank you very much, Robin. Uzma.
Thank you. I just wanted to mention how impressed I was. Robin and I did an evening walk around a couple of weeks ago, and actually it is very different out of hours, but to see it despite the emergency department being actually very, very busy, it was impressive how seamlessly it was working. We spoke to the nurse in charge, and seeing what she monitors on a nightly basis was just incredible. And the site office, they were like swans. Clearly there was a lot they were managing, but they were very calm and so walked away thinking, oh, this is fine. But actually they were all working very, very hard behind the scenes. So it was a privilege to be able to see it that night. And thank you for Robin for giving up an evening to take me around.
Pleasure. Elizabeth, thank you for doing that. Ian.
Yeah, thank you for the report, Robin. You touched on the section 3 of the report and the maximum ambulance holds, and I was quite struck by that we've had in both months patients waiting over 12 hours in an ambulance, not even just 12 hours in the department, which is what we're trying to actively reduce. It was just to understand, do we have a review process of those extreme long ambulance holds to look at opportunities for where there might have been different decisions made in terms of how we offload, how we prioritise in that kind of continuous learning approach?
Yes, we do, Ian, and in fact this very week we're strengthening that further by actually picking 3 areas that we're specifically undertaking daily. We're calling them spotlight reviews. They're undertaken in the spirit of the root cause analysis methodology, and we're working our way through how we make sure that we capture those outputs in the most logical way that we can, so that then we can make sure we've got very targeted actions specifically for them. Further to that, the extraordinary clinical vision and flow meeting we had this week spoke of overarching themes that we need to get right. That's why in the document you can see that we've got that this is how our organisation needs to be shaped, and the SOP, the standard operating procedure that I mentioned earlier, that is now with our clinical directors for further workup as we get ready to initiate further trigger points. That if an ambulance wait goes beyond set times, we will pull those levers that we're predefining, which will allow us to have not just an RCHT response, but a system response as well. But that standard operating procedure still has some more work to do because it's going to need our system partners to be part of that. But that is starting to get some very real structure behind it.
Robin. Are there any other comments or questions? Aled Jones, Associate Non-Executive Director.
Thanks, David. I was just wondering, in terms of the DARSI priorities around digital and the move away from hospital into community, whether you could just give us an oversight of progress there on digital innovation. Are we embracing and harnessing digital enough? Where are we on that journey? Is there more to do? Are there any examples of what we're currently doing, what we would like to do?
And the whole board with that, Aled. As a Cornwall-wide system, we've done a lot of work with how we can use their digital platforms, mainly run by the 111 service, to enable patients to use online tools to be directed to the best location for them. on a very basic level, from a digital perspective, we make sure that we publish across our whole system on our website what the weights are across the system to help inform patients. We use a range of digital platforms to keep the public aware of what's happening in the organisation. And we also use those digital platforms to enable all of our staff to be kept abreast as to what's happening on an hour-by-hour basis, things popping up on your screen so you can see what's happening in the emergency department. We are doing more work with how our teams use our own internal digital tools that already exist to be able to make decisions faster in terms of how we allocate patients and how we check that we've moved patients to the right locations. And then there are a range of tools that will become more available to us as the eCare project rolls out. And there are some products that we're now looking at. Can we accelerate how we can get access to them this side of the eCare go live, which will not only benefit urgent emergency care access, but also will be things done, which means when we are switching on the eCare, those bits are already done and we're already using them. So the two of the 5 priorities we have, 2 of them are starting to come together in that regard. But we can do more, but we need longer time slot.
Thank you, Ali. Are there any other comments or questions? Okay, so
Sorry, Alison's got a hand up.
Alison?
Yeah, just a quick comment. AI obviously is the big opportunity in digital for us in the NHS. So there is a whole range of things that we are looking at. And I'm facilitating a workshop across RCHT and CFT on looking at the opportunities, but also considering the risks in relation to introducing AI.
Thank you, Alison. If I could, I know it's anecdotal, but if I could provide my little bit of assurance from several visits now, including 2 with the Chief Executive, where we've attended the morning huddles and then toured around the department with clinicians. Everybody I meet, without exception, has a really good understanding of the need to move patients through the hospital. They understand the issues around flow, they've got access to data, and they're all, in my opinion, working as hard as they possibly can to achieve our objectives. Now, that's not to say it's good enough, because we still face these challenges. And we are trying to say in front of the public, we recognise that we face these challenges. We're working very hard with all the advice we can find to, for example, do more in terms of same-day emergency care, acute medical unit, discharge lounge, triage, and all the things that sort of hang off the emergency department, and doing our very best with the South West Ambulance Service to reduce ambulance waits. We have ups and downs, but I think we can, and correct me if I'm wrong, Steve, but I think we can detect a trend of improvement.
Yes.
Sometimes, we have a difficult period. We had a difficult period after the bank holiday this year, but we do recover more quickly than we did. And the broad trends are trends of improvement. And therefore, there are some green shoots. But, Steve and colleagues are working harder than ever, really, as their top priority to make sure that improvement is maintained and sustainable and comes closer to the constitutional requirements.
Yes.
Is that a fair comment, Steve?
Absolutely right. That's it. Certainly, that there is improvement. That we see that in the example of we as an organisation recover much more quickly when we have times of extreme pressure on the organisation. We see that we have fewer extreme long waits from an ambulance hold perspective, and we're absolutely clear that we must find ways to go further and faster and have greater impact. And I'm struck by the determination of all of our clinical and operational teams to do exactly that. Robin referred to an additional clinical vision of flow meeting that we held with executive directors, clinical leaders, operational leaders earlier on this week. And that was a great example of the challenge we're facing, but also the determination that our colleagues have to find ways to work differently together to enable us to make further improvements.
Well, the other thing I'd say before I bring Isabel in is I'm very pleased that the executives are having these listening events. So it's not just executives telling people what to do, it's listening to the staff and their lived experience and making changes as a result. And that's really the sort of learning organisation we want to be. Isabel.
Thank you. Thank you, David. I totally agree with that last comment. I think it's really important. I don't want to prolong the discussion, but I just, as I was listening to Robin and then Steve, just mindful of the fact that, you know, a good proportion of residents in Cornwall actually face east across the Tamar for their emergency support. So it was just a question or a comment to say, are we making sure that in some way we're joining up our thinking with our colleagues over in Plymouth in the acute sector, so that we can learn from each other and support each other, and also ensure that our residents in North and East Cornwall, of which I happen to be one, can be assured of getting the best possible service from Darriford.
The short answer is yes, and a bit of detail to that is 3 times a week the region pull together coups from across the region with SWAST on ambulance handover, performance and learning and sharing a learning environment that we have, and UHP are represented on that call.
I think you just owe 40p now.
I have.
Yeah. Thank you.
If I could just briefly comment, unfortunately, Isabel, both University Hospitals Plymouth and Royal Cornwall Hospitals are facing similar levels of urgent and emergency care pressure. So if we looked at, for example, the ambulance handover average measure, I think for the last month we would have been marginally better than University Hospitals Plymouth. So that shows, I think, the level of challenge that both of our hospitals face, and both organisations I know are working incredibly hard. We receive regular information from University Hospitals Plymouth on the steps and options that they're taking. Of course, in their situation, that they are also progressing a new hospital programme with the new emergency department, which has the potential, once that's concluded, to give more capacity. So I know colleagues are looking forward to that in Darriford as well.
Thank you, Steve.
Thank you.
University Hospitals Plymouth have just appointed a new chief executive, so we look forward to welcoming him here soon. And of course, we'll shortly be part of the Cornwall and Isles of Scilly and Devon Integrated Care Board, so that all the acute hospitals in Devon and Cornwall will be under the same umbrella. Are there any other comments or questions? If not, then I think we have to note the update on urgent and emergency care performance and note all of the actions which are being taken to improve the situation. And as I said before, this will be an item on Section A of our agenda at every public and private board meeting. Could we move on then to Section B, reports and matters from committees? I think, Lindsay, this is the first time in public that we've had this format. So I just wanted to say before we go into the actual items, that what we're trying to do here is to draw together everything that comes under the remit of a particular committee into these various committee reports. And what the committee chairs will do is summarise the assurance sought at their meetings, and also issues that they feel are so important or require board discussion that they're escalated to the board. I want to emphasise this doesn't mean that any board member can't check or challenge anything that's in these reports, but we should bear in mind that they've been carefully worked over by the committees concerned, and therefore, prima facie, we should trust our committees and only discuss things which have been escalated or where you want to check and challenge any particular point. So if I could provide that little bit of context, and then say that for some of the committees at least, not all of them yet, because some of them met before the new system, we've tried to tighten up the reporting and not put everything into a bullet point, but just to pick out the main points. And Lindsay, I think you might have wanted to say something about the development of those reports.
Yeah, so thank you very much, Chair. So there's a new format to the way we present our assurance reports from our committee meetings. Obviously, we've talked to our chairs of our committee meetings, but it's more of a narrative, as the Chair has explained. But obviously, we welcome any feedback. But you'll note that significant change in the format of how we present that information.
Lindsay Neave, for members of the public, as our company secretary. So having said that, by way of introduction, the first committee we need to consider is our Quality Assurance Committee, which is chaired by Isabel.
Thank you very much, and I'm feeling the pressure for going first in terms of the new format, but I'll do my best. I think everybody will have read the report, so that saves a huge amount of time in the 2 minutes that I've got available to present. So I think what I'd like to do is just highlight the fact that there are two separate reports which will follow my speech in terms of a maternity and neonate safety report and safer staffing, both of which Kim will pick up following me. A couple of things that I'd really like to highlight for the board and for our public is that we do have a shared meeting between our two quality committees at RCHT and also Community Partnership Trust. And the three areas that I think we've been focusing on have been safeguarding falls and pressure ulcers. And at the moment, we're not meeting our targets around falls and pressure ulcers, but we are keeping a really close eye on the work that's going on across both organisations in that respect. Coming to the key items for Royal Cornwall Hospitals Quality Committee, there are three areas that I think we wanted to escalate to board, one of which we've already just been discussing in terms of the urgent and emergency care, where we are keeping an eye on that at our committee meetings every month as well. And Robin is very kindly providing us with updates on a regular basis. So we're, as I say, we're monitoring that very closely. And then there are two areas of concern that have been a concern for a little while and continue to be of concern to us in terms of assurance. The first of these is around the services provided for patients with fractured neck of femur, where we're not meeting some of the targets that we would be hoping to achieve. And our Chief Medical Officer is leading some really forensic work in terms of looking at how we improve those services and those outcomes for our patients, which is really critical because when we're not meeting our targets on falls, we can anticipate that the pressure will only increase in terms of the service for fractured neck of femur. So we have to think about the link going across. And I think the other area is our stroke service, where we're now working on the outcomes of a peer review undertaken by the Royal College of Physicians. And that action plan to try and improve our stroke services comes to the Quality Committee via the executive leadership team meeting as well. So everybody is very familiar with the actions required to improve our stroke services. And there's also a system-wide piece of work going on around stroke as well, which again, our Chief Nursing Officer and our Chief Medical Officer will be only too familiar with. So those are the three areas that I wanted to highlight to the board particularly, but there were a couple of other things I just wanted to flag up very quickly. One is that in terms of all the requirement to look at cost improvement across the organisation, what has been really impressive and also equally important is the focus on our quality and safety when we're considering cost improvement. And so we have quality assurance mechanisms to make sure that those changes that we're making do not impact the safety and quality outcomes for the patients. So they're central to all our schemes. I think the second thing to flag up is, and people will be aware nationally, there's now an independent investigation into maternity and neonatal services, and I'm sure Kim will want to say more about that in the next item. And then finally, I think across the system, we're involved and engaged with a process to look at a rapid system quality review, looking at urgent and emergency care and trying to minimise harm. So those are really important pieces of work that are taking place with us and also beyond the walls of Royal Cornwall. So I think I'll stop at that point, David. I think I may have overrun, but hopefully not by too much.
Sorry, Isabel, if I wasn't clear enough about the executive director introduction.
Well, I could have half an hour.
I appreciate the committee chairs may need longer than 2 minutes, but maybe not 30. So is there anything?
That's fine. That's absolutely fine. I think I'll pause.
Okay. Thank you very much, Isabel. Thanks for all you're doing on this committee. So the particular areas have been highlighted by Isabel. But are there any comments or questions for Isabel in terms of the issues she's highlighted in particular? And then she can either comment or ask executive directors to comment. Kelvin Hipperson, who's our, I'm not sure your job title, Dual Chief Information Officer.
plus a little bit more in terms of our system, obviously, as Integrated Care Board as well. So it actually is a nice intro to the point. I'm perhaps going to add, if it's okay, Isabel, the Data Security Protection Toolkit item seems a very dry thing, I know. It's about technical things. But actually, this year, that toolkit fundamentally changed as part of national policy. We absolutely welcome that national ambitions for protection, particularly from cyber, are being increased. But of course, it brought an enormous burden to our team. And in a little report like this, it's lost a little bit. At one point, it felt like it might be impossible. But the teams have actually, across the system, because we do this for our whole system, turned that around. So I just wanted to call out that actually, small thing, it's done, but actually an enormous amount of work and teamwork across our whole system. They celebrate for about 2 minutes and then they start work on next year's.
Thank you, Kelvin. Very important.
Yeah.
Adrian.
Yeah, just responding to that point, Kelvin, I actually chaired the Quality Committee in June, where we did discuss that at length. Actually, we recognised the difficulties and the changes to the process, but we did acknowledge that and we did discuss it at length.
I think that Isabel has highlighted the right things in relation to stroke, fractured neck of femur, broken hips, mainly in elderly people, the CQC actions and UEC performance. So is there anything anyone wants to add on those escalated items or anything you want to add, Steve? The committee's very focused and has covered it very comprehensively. So if we could note the reports from the May and June meetings of the Quality Assurance Committee, and then with the same sort of principle of bringing all the quality related issues into one place, move on to item 9.1, which is the maternity and neonatal safety monthly report, which we are of course required to have following the Ockenden review. Kim, could I ask you to introduce it, please?
Yes, sure. In the spirit of, Chair, of what we've just said, and as Isabel has highlighted, there were no areas of concern identified for escalation to the board as regards this paper. We are fully cognizant of the national review of maternity and neonatal services, and as a board we have been having a comprehensive paper that discusses all elements of improvement, quality and safety for our neonatal and maternity services for the last 2 years at least now. So I haven't got anything else to add, but would just say, probably noting our continued commitment to improve qualification in specialism within our neonatal unit, and we've taken further actions to be able to reach the 70% target, noting the very, very complex nature of the specialism and the ability to get all of our staff up to this level. And the only other one is the anaesthetic consultant prompt training projections, because that is one we absolutely need to be fully cognizant of and be able to reach in the intended deadline. And I shall leave it there.
Thank you very much, Kim. Are there any comments or questions for Kim? If it's appropriate, Kim, I just wanted to say, reading this report and the patient experiences that were described, I can only describe as heartbreaking, really. And I'm sure as a board, our hearts will go out to all the mothers and families involved, but also to our staff who have to make incredibly difficult decisions. And you've described to me offline the support that's offered to bereaved families, and also pregnancies that occur after bereavement. And I just thought that was all very powerful. And I'm sure as a board, we'd like to, say that our hearts go out to those families and our thanks go out to our staff. So, yes, we've got a couple of hands up. Matt, could I come to you first, please?
Thank you. Yeah, there is an incredible amount of hard work and emotion involved in the care that's provided. Just to celebrate the team and the neonatal outreach service being noted in the British Association of Perinatal Medicine. document, just to say an example of excellent practice and how we're being innovative and adapting to support the needs of the babies and families who've come through the neonatal unit and the transitional care unit, just to help them the next steps in life and to really support them. I think it's just worth highlighting the some of the innovative work that we're doing down here is being recognised nationally.
Thank you, Matt. That, I guess, is part of the reason why we've been awarded the Women and Children's Hospital. Adam.
Thank you, Kim, and thank you to the team. Just to take us to section 6, the compliance overview, and to firstly absolutely recognise the amazing work to have got a green rating in the table for 248 out of 296 actions expected nationally to be addressed. So I feel almost churlish, but just to ask about the 3 that are red, and just to check whether there's anything the board needs to be concerned about in the 3 items that are marked as red.
No, the three ones that are marked as red have been highlighted before as more national issues and slower to progress, but it doesn't mean that we're not cognizant of that and in regular update with both region and national.
There are some comments in the chat which I don't think is publicly accessible, is it, Lindsay? Particularly from Richard Kramer. So if anyone who has made comments in the chat wants to say anything, please do. But otherwise, we've noted that in the chat. Richard.
So I was about to put my hand down again. So yeah, it was just because we have the highest number of deaths of people with a learning disability and autism in 1 year. And I think that's important to note, particularly around the inequalities that disabled people may face. And I know our specialist teams, and I want to stress this, go over and above to ensure good care. And actually, we manage some of the gaps in the wider community. But I just wanted to note the number of deaths from cancer are increasing, and what are we doing around to promote screening for bowel cancer? How can we improve face-to-face annual health checks as well?
Thank you, Richard. Kim, would you like to comment?
No. On the bowel screening, sorry, I was flicking pages. Richard, we've done a lot of work, especially with our learning and disability teams and our cancer teams, to make sure that we offer the most earliest screening opportunity available, and to pick up through our work with our community and GP practices, as well as other networks, to be able to make sure we're having every opportunity, not just for cancer screening, but for any other screening for this very vulnerable group. But always more work to be done as we move forward. Thank you.
Okay, thank you, Richard. If there are no other points, I think we do need to note the staffing plan and the actions being taken to improve specialty in-service training for nursing resilience, particularly neonatal nursing, and also note the projections for anaesthetic consultant. I'm going to use an acronym because I don't know what it all stands for. Anaesthetic consultant prompt training. Thank you for that. Thank you, Kim. Item 9.2 is the Safer Staffing Biannual Report. And again, this is you, Kim.
Yes, so I'm just going to start, because often people wonder why this report comes to board. So for the members of the public, the purpose of this paper, and it's extremely comprehensive, but hopefully clear, provides credible assurance to board, enabling a unitary board to discharge their accountability regarding a continued culture of safe, sustainable and proactive nursing and midwifery staffing. And hopefully this paper will evidence as a clear, robust, consistent process in place that enables us across all of our sites to measure safe staffing requirements. And I fully recognise this is a big report, and I have to thank both my deputies, Louise and Bernie, our heads of nursing, clinical matrons and our ward leaders, who put an incredible amount of effort, not in just providing and collating the data, but doing that professional check and challenge. It isn't just about the 30-day audit, it's about professional opinion as well as environmental and operational considerations for each service. So whilst being extremely comprehensive, you can see it has 7 recommendations for board, 8 considerations which are clearly outlined, and it is in line with national guidance. All of our staff have had the updated training. We do this biannually because we have seasonal variation, and in Cornwall, summer sometimes can feel just as busy as winter, but we're already gearing up for September's. So we take into account, and this paper is not recommending any changes in current establishments, but recognises there are some unfunded establishments that we're still supporting, as well as looking at various aspects of activity and outcomes. We will be doing some shorter, before September, some shorter little reviews of what's going on in some of our services. But it's really, really important that we've also benchmarked ourselves both nationally and regionally with aspects of the model hospital and what is called WOW, which always gets me, is weighted activity unit, which is really important because that not just gives us our check and challenge, but how do we measure regionally and nationally? And actually, we're in quartile 2. We indicate more productive in our own services than others, and we spend less per cost medium. And I think that's testament to a lot of the work that's done daily as well as monthly as regards looking at staffing, whether it be on a daily basis to cover gaps or whether we're looking at long-term establishments. And our planned versus actual is 95%, which remains consistent and above average, which is important. Peds dropped slightly at 93%, but we know that we're doing a lot of work in paediatrics and neonatal services. And I think I shall leave that there, Chair. Thank you.
Thank you very much, Kim. Given the challenges we have with recruitment and retention in Cornwall, I took a lot of assurance actually from this very thorough report. Thank you. Any comments or questions for Kim? Bear in mind this has been thoroughly gone over. Okay, thank you very much. I'm going to move on while I have the chance. To item 3, another dense but fascinating report, the Learning from Deaths Q3 report. Could I invite our Chief Medical Officer, Dr. Mary Kane, to introduce this, please?
Thank you, Chair. Yes, it's a fairly lengthy report with an equally lengthy set of appendices, which it does contain an awful lot of information. I'll try and pick out a few of what I think are the key points, and I'm happy to take questions. So our hospital standardised mortality ratio for Q4 sits at 96.35, which is within the expected range. We continue to have a downward trending crude mortality rate and a stable summary hospital mortality index, and our CHT is benchmarking well regionally for mortality indicators. That said, there are 3 alerts that we're aware of. Anemia is a new alert. We're talking about a small number of patients within this alert, 15, and small numbers of patients can sometimes skew the value. We've done a coding review to ensure correct coding, and we're now looking at each of those cases and doing a structured judgment review just to understand whether there is any learning or any themes within those 15 deaths that we need to take note of. When Isabel presented the Quality Assurance Committee paper, she alluded to 2 areas of focus, rightly so. We are flagging as an outlier with the Sentinel Stroke National Audit Programme on stroke mortality, and that's reflected in an increased stroke hospital standardised mortality ratio. It was mentioned there had been recently an invited review by the Royal College of Physicians looking at the system stroke pathway. We have a trust improvement group already working to address the necessary actions to improve our performance in stroke care. And we also have a system group that is looking at the wider system pathways. And already we are seeing, as a result of the implementation of the new medical model, improvements in time to senior review for stroke patients and timely admission to the stroke unit within the 4-hour standard. And this will continue to be tracked and will continue to be reviewed on a monthly basis for the time being within the Quality Assurance Committee. Fractured neck of femur was also mentioned and is triggering as an outlier for hospital standardised mortality, whilst actually not triggering as a mortality outlier for the National Hip Fracture Database. It nonetheless is an area of concern. We are, and it's recently been audited and presented at the Clinical Effectiveness Group, and we particularly looked at our performance against the key performance indicators within the National Hip Fracture Database. There is a real focus with an internal improvement group to improve those metrics, with a particular focus on timeliness to get to theatre within the 36-hour window. And again, that is something that will be reported regularly into the Quality Assurance Committee until we're assured of sustained improvement within those metrics. 97% of deaths in Q4, quarter 4, were reviewed by our medical examiner, and 7% of those were subjected to further review where any area of concern was identified and no themes were found. In that same quarter, 21 summary reports were submitted to the coroner, and RCHT participated in 10 inquests. RCHT was not subject to the any preventing future deaths notices being issued by the coroner during that quarter. 13 priority deaths were reviewed by structured judgment review. And we've got 3 further outstanding at the time the report was written. I believe they've now been concluded. All of those were reviewed with the mortality review oversight group process, and learning from those is shared with care groups, discussed in departmental mortality and morbidity meetings. And I apologise for the incomplete table in the report around the frequency of the mortality and morbidity activity within service groups and at specialty level. That's now being picked up by the clinical director for quality, safety and clinical effectiveness to make sure that those reviews are happening on a regular basis and the learning is taken. You will notice within the priority death reviews, there is one report where a death was deemed to have, over the course of the pathway of that patient, received poor care, and one very poor care with some evidence of avoidability. Both of those are subject to a process of review, and the learning will be taken from them and shared. There was one death in the quarter that was subject to the perinatal mortality process, and that was sadly a death of a stillbirth at 26 weeks. And again, relevant learning has been shared with the care group. There are 3 complaints within the quarter associated with the death of a patient. The details are within the report, so I won't go into that, but I think it's important that I highlight, when you read through those narratives, communication is a thread within all 3, and I think we have to take notice of that and look to see if there's anything else we could be doing around our communication at what is clearly a really difficult time for those involved, both from a staff and a family's perspective. So I think that requires a little bit more scrutiny. There were 9 deaths of people with learning difficulties or autistic spectrum disorder within that period, 8 of whom on review had care graded as good or excellent with no evidence of avoidability. There is 1 review ongoing that I can't report on at this point. The only other thing I'd like to say is the report contains details of all the deaths within the cohort of those with learning disability and autistic spectrum within 2024, and the numbers have risen when compared with the previous 2 years. But I would like to say that it is clear that the learning disability team are doing an enormous amount of work. They were able to be involved in more than 80% of those deaths, and almost 80% of those patients who did die had a hospital passport at the time of death, and those that didn't died within a very short window of admission and wouldn't have had the opportunity to have had that input. And finally, I want to highlight the enormous amount of work that's being done by the Learning Disability and Autistic Spectrum Disorder team. And I note that in the last year, they have been able to support 5,211 patients, which is a huge amount of work and really important work. So I think that's my final comment. Happy to take questions.
Thank you very much, Mary. I think partly because of Richard's challenges, we've all been paying particular attention to the issues around disability and learning difficulties and autism. So I don't know if there is anything you wanted to say, Richard. The report is very comprehensive in those areas. Any comments or questions for Mary? I think it's right that we take a little bit of time on this very important matter. And I'm very pleased to see all the comparative data as well. So, you know, you can sense check against what's happening in other trusts. Isabel.
Yeah, I just wanted to recognise the work that goes on internally looking at this data. And as a non-exec, I've been really fortunate, I think, to be invited to join when I can the mortality review group, because I've been really impressed with the level of detail that group looks at, and picking up the trends and then acting upon those trends, which is the important bit for me, is, you know, what do we do with the data? So yeah, really good process, I think, within the organisation looking at learning from deaths. And it's just sad that we have to have a report around learning from deaths, but very important that we do scrutinise it. So thank you, Mary, and thank you to everybody involved.
Okay, thank you. I'm not rushing you, but I'm just saying that we'll move on unless there are any other comments or questions. And if I could just pop back to 9.2, I probably should have said, Lindsay, that there were 8 items in the report which are too long to read out, but which the board is asked to note. I'm sure you've captured those, but just thought I ought to say that. And in relation to item 9.3, the learning of deaths, with thanks to Mary, could we note and endorse the Learning from Deaths Q4 24-25 assurance report, and note its recommendation and approval from Quality Assurance Committee. So if we could just do then Finance and Performance Committee's assurance report to board, which is chaired by Adrian Davis, then you can have a break. Adrian.
Okay, thank you, Chair. The committee acknowledged the positive work that was ongoing across the trust in delivering the financial targets in the first 2 months, but noted that there's a significant increase in that requirement from month 3 onwards. So we will be focusing on that issue through the remainder of the year. We looked at the proposal to replace the LINAC 4, the radiotherapy linear accelerator, which is on the agenda later on today. We had a paper, a very interesting paper, which was lessons learned from the cost improvement programme, delivery planning for last year, which the committee recommended should come to board to see that. We also had a discussion around the major capital programme, and in particular the Women and Children's Hospital and the proposed preferred new way forwards. And there were 2 areas with regards to that where we're seeking further assurance that we hope will be brought back to our next meeting. The first being the gap, the expected 6.6 million that the trust was getting for work on that programme, and that was 2.1 million. We received 4.5. So the impact of that 2.1 million reduction in that income and what that will have on our operational plans going forwards. And the second area where we're looking for further assurance is in regards to the critical electrical infrastructure. Two areas in relation to that. One, the estimate for the work has come in significantly over what was anticipated, but more importantly for the committee was there's a long lead-in time for that work, and we're working to quite tight deadlines and gateways for the Women and Children's programme for the new hospital. So it's really that we can achieve those targets, those gateways with regards to the infrastructure work. And I'll leave it at that, Chair.
Well, thank you very much, Adrian. Could I just first of all ask Adam Broom, who chaired one of those Finance and Performance Committee meetings and is also the Check and Challenge NED for the eCare programme. It's not compulsory, Adam, but whether you wanted to say anything as well.
Thank you, Chair, and thank you, Adrian. Just in terms of the May meeting, we kind of covered, so I won't say very much, but we covered, and then obviously the June meeting subsequently continued to cover where we were with the Women and Children's Hospital, where we were with the eCare project, which was also covered in Steve's, the Chief Exec's, earlier report in terms of where we are with the eCare project. And I was delighted to see that referenced by John in terms of the veterans, was talking about the importance of eCare. So it's clearly spreading in terms of the message about eCare, which is really great, really important project. But it is a project that we are now aiming to deliver by June 26. So we discussed that and wanted to bring that to the board's attention. And the other area that we wanted to bring to the board's attention from memory from the May meeting was around the NHS 111 contract, where there's ongoing discussions about the future contract. And I'll probably leave it there, Chair.
Thank you very much, Adam. So there are two things, if we take them sequentially. One, is there any further comment or suggestions following the review and the learning from cost improvement programmes, which I guess Steve and Ian is standing us in good stead for developing the programmes for this year and next year. But anything else board members would like to add around that learning, which I thought was very rich and very open. So thank you, Ian. Or if not, is there anything anyone wants to add or question around the eCare programme and the associated risks with the 111 contract, which has been gone over carefully by the Finance and Performance Committee? Ella,
I don't think so. I think we've discussed previously the 111 contract and what we're doing, and we're enacting that. So I think it's fine for us to leave it as it is. Thanks, David.
111 performs pretty well in Cornwall, doesn't it, compared with many other parts of the country? So if not, we're invited to note the report from the May and June 2025 meetings of the Finance and Performance Committee. And then just one more thing to do before the break. Item 10.1, which is the month 2 revenue financial report. We're coming towards the end of month 3 now, but this is the month 2 report, plus anything else you'd like to add, Ian.
Thank you, Chair. Yeah, so as you said, this is the financial position after the first 2 months of the year to the end of May. So broadly speaking, we're on plan in month and cumulatively with a small £70,000 favourable variance to that plan. However, it's really important that I flag to board that is a £2 million deficit plan in month. And so 4.1 million deficit cumulatively. We signed off an operating plan that had that profile in it. June and July are the final months with deficit plans, so 1.3 million and 900,000 respectively. And that's exactly as Adrian alluded to, one of the key focuses of Finance and Performance Committee in terms of the risk of needing to make sure we deliver that reduction in our expenditure through the year to keep us on that track. Our work total time equivalents and our agency continue to perform well and on a downward trend, and on agency in particular, and it links to Kim's report on the safer staffing update. This time last year we were spending around about £1.6 million a month on agency, and you can see in the report it's averaging at 700, 800,000 pound, and we saw a slight reduction again in month 3 on that, which is really positive. Our variable income, so this is elective related outpatient procedure type related activities, slightly above plan, as you'll note in the report, but again the plan in April and May was consciously slightly lower for those activity aspects. From a cost improvement perspective, we've touched on it a couple of times, and we've touched on the lessons learnt document, but in terms of progress for the year, we slightly exceeded in month 2 the delivery requirement. Cumulatively, we're about £300,000 behind plan, and we continue to work closely with all of our colleagues and our care groups with the support of our improvement director on increasing and delivering on what are some really significant changes to our organisation, whilst also keeping that aspect of equality, quality, impact assessment throughout that. Our cash position remains positive against the plan. At the end of May, it was 31.2 million compared to a plan of 18.7. Some of that is timing related, but some of that is actually an underlying betterment against what we'd expected. And Finance and Performance Committee will receive in its normal process of business a quarterly deep dive report to the meeting later in July. In terms of finally just on risk, the clearly articulated plan risks which remain are the SIP delivery and the profile that we've talked about through the year of that, as well as the variable activity elements and delivering that elective activity levels. The paper just sets out on the final page of the report some new and emerging risks that at this stage in the year it's really important we keep a broad spectrum view across. Pay award we've touched on earlier. We've subsequently, since this paper was written, had that confirmation of how the uplift will apply to our contracts, so we're working through that, as I mentioned earlier. The job evaluation process, the letter and covered in Steve's report, is clear about the fact that we need to make sure as a board that we've got clarity and robust processes in place around that. It's also clear that any changes resulting from that need to be managed within existing budget constraints, so it's appropriate that we are mindful of that from a financial risk perspective. But other than that, I'm happy to take the report as read and any questions from colleagues.
Very much, Ian. And thank you to you and your team for all the work that's going into this. And I guess we would say so far so good, but there's a lot of challenge still to come.
It certainly is, yes.
Any comments or questions for Ian? If there aren't, I think we're asked to note the month 2 financial position with a small variable variance, but as Ian rightly emphasised, on a planned deficit at this stage, and note the progress and current risks in relation to the cost improvement programme and the emerging financial risks, including industrial action, which you've outlined. So I think that brings us to the break. We're running 5 minutes late, but I'm sure we can recover that. There are some chairman's biscuits, which I assure you haven't been paid for by the NHS, on the table, if you'd like to help yourselves. But they are disguised, of course, as a basket of fruit. So could we be back, shall I say, at 20 past? If we could reconvene at 20 past for the rest of the business. Thank you very much. Welcome back, everybody. The meeting, please. I hope that, yes, I can see him on screen, that Richard Kramer is with us, because we're now moving on to item 11, the People and Culture Committee Assurance Report to the Board. So could I hand over to you, please, Richard?
We can't hear him.
Can't. That's it. Okay. We couldn't hear you, Richard, but we can hear you now.
Great. So there's a number of reports. I will take us through our work in organisational development and occupational health, and then we've got to consider and receive the gender pay gap and workforce equality standards report, and then we've got Joe coming in to talk about Freedom to Speak Up reflection tool. So in terms of organisational development, organisational culture, I think it's fair to say that there's been a lot of discussion about culture, both at the People Committee and at board meetings. It remains an ongoing and live discussion. But I think it's important to note that since those discussions, there's been agreement to establish a culture task force, that we're going to re-establish the Quality Improvement Hub, so that we're really embedding quality in everything that we do. We're looking to have a more strategic approach to our communications function. We are going to include inclusive culture as part of our performance accountability framework, and we will consider the case for investment in leadership development. And we also want to prioritise well-being for our staff and getting the basics right. And thank you to the generosity of Alison and her team. I had a separate meeting with them to discuss a wellbeing action plan that will capture our current work and wellbeing, looking at leadership communications and how we manage and support staff during their whole employee cycle. Part of that is occupational health. That's only going to be one element of the wellbeing plan. And on occupational health, that does still remain a concern. There have been a range of actions to improve the provision and resource within the current service, both in investment in clinical and consultant support, but we still need to make a decision about the overall future of the service through an understanding of other models, and so it still remains a matter of concern. So I can pause then and then come on to the pay gap reports and other reports.
So questions for Richard? Okay, Richard, I think you can press on. Oh, sorry, there's one from Ian.
Yeah, just to pick up on Richard's comment there and the escalation in the report in terms of occupational health, just to say that myself, one of the team, Dorothy from Alison's team and Bernie from Kim's team have been meeting regularly on that. We've got another meeting actually tomorrow in terms of following up on that and the options and how we seek to get further options and assurance into that work. So just to update board on the progress that's been made with that, it is being followed through.
Thanks, Ian. Any other comments? I know occupational health has been an issue that's been on the desk for some time, so it's good to see that there's some progress being made. I think is there another? Oh, Alison.
Yeah, just to say, currently there is one vacancy within the team that's been approved by EVRG and out to adverts. If anybody is interested in occupational health nurse, please do apply.
Thank you very much, Alison. I think you can carry on then, Richard.
Yeah, so the next is we're here to recommend and receive the Gender Pay Gap and Workforce Equality Standards reports. So just to note for clarification, at committee we saw a draft of these reports rather than the final reports that are presented today. And it was commented at that committee and by Adam subsequently that particularly for the pay gap reporting and workforce equality standards reports, they're quite dense documents, and it would be useful to have a summary that's available on our website so it's easy to absorb and understand. In terms of the pay gap reporting, I think we've seen positive trends in the gender pay gap for women, but we haven't seen that. We've seen negative trends for the ethnic minority pay gap and disability pay gap. I think we need to, the recommendations are to have a deep dive into why women are not applying or being recruited into upper quartile level roles, and we need to promote more ethnic minority staff into higher paid roles and support their progression. In relation to the workforce equality standard, the committee expressed concern that some key metrics have deteriorated, including the percentage of disabled staff that require reasonable adjustments, and the number of staff receiving reasonable adjustments has reduced to below the national average of 73%. We've also seen more disabled people entering the formal capability process, and the general trend for valuing staff with protected characteristics is not moving in the right direction. In terms of the percentage of staff from ethnic minority background, that the number of staff is increasing, which is really positive. But ethnic minority staff are less likely to be appointed from shortlisting. They experience more harassment from both staff and patients, and just over 50% of staff are looking to leave the trust in the next 12 months. There are a range of actions identified in the report. but I want to say that demonstrable leadership to encourage people to speak up is essential, and that's why the shared objective of the chair and CEO to reduce racial discrimination and more widely to improve sexual safety as measured by the staff survey is critical. So that's what I wanted to say by introduction.
Thank you very much indeed, Richard. In my meeting with Bishop David, having worked in Africa, he's got a very strong interest in our global majority staff, and that's something he's very passionate about as well. And I know when Steve returns from leave, he and I are going to sit down and really talk through an action plan to deliver our shared objective, both in that area and in the area of sexual safety as well. So thank you for your support and guidance and leadership in that area. In terms of the gender pay gap report and the workforce race equality standard report, Alison, are there any matters on either of those reports which you would like to add to in addition to what Richard has said?
Yes, if I have time, Chair, to quickly just cover a couple of the highlighted points, that'd be really helpful. I just wanted to say a special thank you to Karen Jarvel for her support in finance as well on these two reports, because as Richard mentioned, they can be quite dense to read. They are a legislative requirement on us. Both the Workforce Disability Equality Standard and the Race Equality Standard. As Richard's covered, it's gone to committee. There is a requirement to publish them before the end of October, but the real work actually starts now with our consultation with JCNC as of Tuesday, and also with the work with the employee networks, and Richard mentioned task force as well. So in terms of the Workforce Disability Equality Standard, I just wanted to point out there is still a high likelihood of disabled staff entering a formal capability process, and the number of staff that has gone through that has more than doubled to 23. We have been making reasonable adjustments, but for the first time last year we've seen a fall of that, which is below the national average of 73%. The number of staff being shortlisted, this is a good news story, has increased. And that has then meant that you're more likely to be appointed than before. So that's one bit of good news. However, we can see from the data that disabled staff don't feel that they do have equal opportunities in terms of career progressions, despite the previous increase in the previous year. And also disabled staff feeling pressure on coming to work. And then if I just very quickly pick out some highlights on the Workforce Race Equality Standard. Last year was a really difficult year in terms of the backlash that we suffered as a country in relation to the riots, and we can see that our ethnic minority staff have had a worsening employee experience, and that's borne out in the data. And that starts right from the point of shortlisting. And sadly, I need to report that you're more likely to be appointed by 2.5 times if you're white than compared to any other ethnic minority protected characteristic. Also, the percentage of staff from an ethnic minority background has been increasing in terms of experiencing that discrimination. Excuse me, I'm just going to take a drop of water. And that's currently now sitting at 25%. So the other point I just wanted to draw out of this report is that 50% of our ethnic minority staff are looking to leave in the next 12 months. And that is not a place that sits comfortably with us as a trust. And therefore, we have decided to put this task force into place to make sure that we listen clearly to our ethnic minority colleagues and we take action. And whilst these reports have action plans at the end of them, we need to enhance those actions through the listening that we need to do with our staff. So thank you, Chair.
We're openly and transparently discussing in public these issues. And certainly from the chair, I would like to assure our global majority staff, first of all, that we're exceptionally grateful that they're with us and recognise everything that they do. And we're going to work as hard as we can to overcome these challenges that you've described, which shouldn't be happening. Ian.
Yeah, thank you. So my comments are in the context as executive lead for the Disability and Long-Term Conditions Staff Network. And just on that point around reasonable adjustments that's been mentioned a couple of times, that's a really key priority for the staff network. And I'm working closely with the network lead and our ED&I workforce lead around a reasonable adjustments guidance. So we rely on separate policies and elements within separate policies rather than having a discrete guidance, particularly around reasonable adjustments and what they mean for different staff. And the concept of a disability passport has been developed by the network, by colleagues, and is something that will form part of that, so that you don't have to explain your reasonable adjustments to every different line manager that you might report to through an organisation or between organisations. So we're looking at doing that in conjunction with our colleagues at Cornwall Partnership Foundation Trust as well. So just as a bit of an update in terms of how that, it's really important. I think we let the networks lead some of that work and support them to deliver that.
Thank you, Ian. Steve?
Thank you, David. I just want to echo the comments that you had made. The workforce risk quality standard summary that Alison has described as stark, and clearly we have significant work to do in the organisation. I'd want to be clear, and I think I'd speak on behalf of the entire board, that there is no room, there's no tolerance in this organisation for racism, for harassment, or any other form of discrimination. Clearly, we are experiencing that, so we need to take action to address it. But I would want to send whatever message is possible to colleagues across our organisation that you are safe to speak up. If you're experiencing harassment, if you're experiencing racism, if you're experiencing discrimination, please speak up. Speak up through a range of routes. Speak up openly, speak up confidentially through the freedom to speak up mechanism. If you feel you don't have a different way to speak up directly to any member of the board, and we will do whatever we can to address this. And I know we are collectively determined to take action and make progress.
Thank you, Steve. That's a very important leadership statement from the Chief Executive to all of our staff. So if there are no other comments...
Yeah, can I just...
Sorry, Adrian, no problem.
Yeah, just... I'm sitting here reflecting on what Alison said with regards to the backlash following the riots in the UK last year. And I'm just reflecting, are we experiencing any issues with regards to the situation in the Middle East? I've recently been reading articles about inappropriate behaviour and attitudes towards Jewish communities, and I just wondered if we'd experienced any of that.
Thank you, Adrian. Alison, are you able to comment?
I think, whilst I can't comment on specific cases regarding Jewish colleagues, as I say, generally the numbers of cases that are coming forward where people are experiencing bullying, harassment and unwanted comments based on a protected characteristic is increasing. And, you know, we had a really positive Equality, Diversity and Inclusion conference last year. We're planning on having another event in the next, well, within this financial year. Really encourage people to come with curiosity to learn, and as Steve has quite categorically said, we have an anti-discrimination statement that we all live by, and it's incumbent on all of us if we hear anything, see anything, that we call it out.
Thank you, Alison. Kim?
I suppose it relates. I think now more than ever, we've got to be really clear of what our position is and what we won't tolerate with the current financial environment, not just at RCHT, but across the system. There's a heightened tension, especially with reductions in workforce and transformations of services, that we do this in an equitable, with parity, and ensure the right messages are going out. I know Joe's joined us, but we can see some of the concerns coming up through Freedom to Speak Up. So we've got to be consistent with our message throughout for all, and that includes not just race, but disability, gender, and everything else.
Thank you, Kim. I think we're going to have to move on if the board is content. It's very important points made there, which it's important that we record. Particularly Steve's leadership statement. We do need to approve the Workforce Equality Standards Report for 2025, noting publication on the Trust website. And in relation to the Gender Pay Gap Report, we need to approve the pay gap for gender, ethnicity and disability annual report, note it, and the action plan, which will in due course be published on the Trust website. Thank you very much. If we could move on to 11.3, Freedom to Speak Up, which is related, I think, to our previous discussion. I hope you don't think this is self-indulgent, but I have warned Steve under no surprises that before I move to Kim, I did want to say something about this because it's important to me and I think to the board. And what prompts me to speak rather than just hand over to Kim is that ever since I've been here, Steve and I have said repeatedly to this board and in public and in podcasts and in staff meetings that people should be free to speak up and speak out. And yet when we come to the board self-assessment, our championship of this is not even mentioned in the report. So it just struck me that if it's not mentioned in this report, we're clearly not getting across to the wider staff. So if you'd indulge me for just a couple of minutes, I just wanted to try and explain why I've been saying that people should be free to speak up and speak out. When I was first approached about this role about a year ago now, I said to the headhunters that I wouldn't be interested in it if there was a board or an executive that put the interests of the organisation before the truth. The first meeting I had with Steve, I said that to you, Steve, and Steve immediately agreed. And that's what made me think this is an organisation I might want to be part of. And the reason I feel strongly about it is if I go back to my time on another NHS board, which I won't mention, I became acting chair of that board because of a whistleblowing disaster, which is all in the public domain, when lots of people had to resign. So I was ended up having to sort it out. And it was around the time that Robert Francis was doing his second report. So I corresponded with Robert Francis because, of course, this whistleblowing issue was one of the things he was considering. And two things struck me at that time. One was, what on earth is wrong with the NHS that Robert Francis has to produce a report with 20 recommendations saying that people should be able to speak up and speak out? Why do we have to have a huge architecture around it? Why isn't it just the culture that people can speak up and speak out without fear or favour? And the other thing I felt was that while I was chairing organisations, whether in the NHS or elsewhere, I would never put the organisation in front of the truth. So I won't name them in public, but there are lots of examples in the NHS of organisations that have done just that and covered things up when things should have been visible and transparent. So what I would like to think is that can never happen here, but if it did, you have my assurance, and I think Steve's, although he can speak for himself, that if we had to refer anything to the police or if anything inappropriate was happening, we would do it regardless of the reputation of the trust. And then if we fast forward to the pandemic, there was a wonderful man called Li Wenliang. You may remember Dr. Liang, and he blew the whistle on COVID in a much higher stakes society than the one we live in, and he paid with his life for it. He was accused of making false comments, severely disturbing the social order, simply for alerting the World Health Organization to COVID. And of course, he later got COVID, and allegedly that's what he died of. But he said one thing which struck me at the time. He said, a healthy society should not have just one voice. So for me, we want 7,000 voices. So if the most junior staff sees the most senior consultant doing something which is wrong, they should be free to speak up. And although I'm non-executive, there's no one more senior than me in the trust. If the most junior staff saw me doing something wrong, they should speak up and speak out. I don't know how I can say it more clearly than that, but I'll keep saying it. And I hope it finds its way into things like reports on freedom to speak up. Sorry to indulge and take up time, but important for me to make that point. I would like to ask Steve if he wanted to say more than what he said previously, and then I'll hand over to Kim. But just to say to Joe Burton, our Freedom to Speak Up guardian, who's with us today, it's really important. If you don't say anything illegal and you don't say anything malicious, you can say whatever you like because we live in a free society. Steve.
Yeah, thank you, David. I won't say much more other than to reinforce the comments that we've made many times, that we would want an environment in the organisation where everybody is free to speak up openly, to speak up, to raise issues immediately so they can be addressed immediately, and then to have the confidential freedom to speak up mechanisms as that safety valve, as that backup, but to have an environment and a culture where everybody doesn't just feel safe to speak up, but feels expected to. There's a responsibility on every one of us to be able to intervene and observe where we see something that may be going wrong. So I think that's critically important to us, but very happy to hand over to Kim.
Thank you, Steve. So with that context, Kim, sorry for delaying you, but
No.
could I hand over to you, please?
No, that's fine. It's sort of taken some of the wording out of my mouth. So I fully recognise that the reflection and planning tool is completed every 2 years, and ours was last completed in February 23, but it is against the 8 National Guardian FTSE principles. And what I will make sure in the front page in future is I have never worked in an organisation where there has been such a strong board-led commitment to freedom to speak up. And whilst that isn't within the 8 guidance of the 8 principles, we'll make sure that it's fully covered. The very, very strong message, I think, and I think Joe can attest to that, is when we go out, everybody knows as a board, and they hear it repeated, that we are fully committed to providing a safe culture, and freedom to speak up is one of those avenues that allows everyone to have a voice, whether anonymously or whether being able to speak up to one of the 76 champions, Joe as guardian, or exec or non-exec colleagues. So I will make sure that that's fully covered in any front page as regards the assessment going forward. But Joe, without stealing any more of your thunder, do you want to go through what you'd like to highlight with the assessment? Noting, I must admit, collating this one was a huge task this year, only because there's quite a lot to consider. And I think whilst we touch on it quite a bit in in meetings, it was great to see that full assessment coming through for those that are responsible as regards their portfolios within this sector. So, Jo, over to you.
Thanks, Kim. Thanks, everyone. I thought it was really important just to acknowledge at the start of this, the announcement that came out on Saturday regarding the National Guardian's Office. So it's going to be closing, for those of you that hadn't heard that. I don't know any more detail at the moment, only that functions will likely to be brought under the Department of Health and Social Care. But I just thought that was important to note that here. And although that decision may well raise questions about the future of the Freedom to Speak Up initiative, I thought it was also important for me to note that the core principles of fostering a safe speak up environment for our staff will remain unchanged. So this reflective tool is useful in terms of highlighting the more work that needs to be done, I guess, from my point of view. And it highlights the things that aren't a surprise to me, being in this Guardian role. So I guess the three things that stand out for me here are the enormous amount of work that still needs to be done in terms of our culture. So work with the organisational development team, the EDI team, and also with our people partners. And also triangulation around freedom to speak up, triangulating data. And when you'll have looked through this report, this is all in there. But I think that's really important as well. And I think, you know, there's a lot more work to do on that. And the other thing, because I'm so proud of our champion network, and I think they do such a fantastic job. And I've just trained some more champions actually. So I just wanted to mention the champions, and our monthly meetings are really rich and diverse, and we have frequent learning sessions that Kim often comes along to. So I just want to thank all the champions because they're volunteering in that role when they were already have very busy jobs, and I think they make a massive difference by promoting freedom to speak up and sharing conversations with people that ultimately may lead them to feeling better at work. Thank you, everyone. I'm really happy to take questions.
Thank you, Jo. I was in a webinar the other day with a very senior NHS England official who was anxious to stress that although the architecture nationally was being removed, there was still a strong commitment to freedom to speak up guardians within providers. So who have we got? We've got Ian first and then Uzma. Ian.
Yeah, thank you, Chair. Thank you, Jo, as well. Just, I was challenging myself, why do we wait 2 years to do this? I know we're required to do it at least every 2 years, but I was reflecting whether as board I certainly would advocate for seeing an update on it, appreciating the amount of work that goes into the full tool, Kim, that you'd mentioned. But I think an update annually on how we're tracking against this, given its importance, would be something I'd recommend us to consider.
Okay. Thank you, Ian. Can we gather up all the points and then Kim can take them under advisement? Uzma is next.
As it's a public meeting, I wondered whether we could just mention how staff could get in touch with non-exec directors who obviously aren't on site regularly if they felt they wanted to raise something with us directly. So it's just whether there's a mechanism for them to do that and whether we can share that publicly so people do know how they can reach us if they needed to, whether it's through Jo's office or...
Richard Kramer is our lead.
Right.
We may come to Richard if his hand is up, so we'll come to Richard. Kim, you've got your hand up.
Do you want to leave me till
Shall I
last?
leave you till last?
Yes.
So then we go to Ella Stracy. Ella.
Thank you. I was just going to mention through the Culture Task Force that we're now setting up. Joe Burton will be invited, if you're not already, Joe. That'll be bringing its way to you very soon. We're just trying to get a date for our first meeting, which I think is really important, embedding this into, you know, it's part of our base culture and what the way we do things around here. I also think we've touched on this before, Joe, and I'm not sure, it's a very difficult area, but how, for me anyway, bringing to life some of the freedom to speak up stories would be really, really helpful. And I know that's tricky because of confidentiality, but if there are examples where people have been through the process and for better or worse would be willing to share their learning, I think that could be really, really powerful, because I think people sometimes are a bit trepidatious because they don't know what will happen and how it will happen. So maybe we can give some thought to that sensitively.
Yeah, thanks, Ella. Yeah.
Richard.
Yeah, I think Uzma's covered the point I wanted to make. I mean, there needs to be a mechanism, and I am the mechanism in terms from a non-exec board director, so I am the lead for Freedom to Speak Up, and people have contacted me so that I'm assured that that mechanism of reaching out to NEDs is in place. I'd also like to thank Joe for the time we spent together, and for Alid as well, who joined our last conversation, and it was really important to get his national perspective. I'm glad Ella mentioned culture, because as I said in my reflection tool, when we hear of people being reluctant to speak out, that's also echoed in our staff survey. It's also echoed in terms of the discussions on culture, and the more we integrate those discussions together, the better. And so I'm really pleased that Joe is part of that culture task force going forward. Thank you.
Thank you, Richard. I think we all have to remember as well that many of our global majority staff come from authoritarian regimes. So speaking out is culturally very challenging for them. Who is next? I think Robin is next, Robin Jones.
There's layers to freedom, feeling free to speak up rather than just freedom to speak up. And it probably will link into the culture piece, but some of those layers is how we, not just us as the executives, but our management colleagues, supervisors, are as accessible as they possibly can be. And I think there's something for us to really challenge ourselves. I say it a lot in a lot of topics, but how often we're using Teams, which means we're putting an immediate barrier between ourselves and people when we're staying in our offices or we're staying at home. And I think there is a challenge for us of if we have more space where people can have that corridor conversation to and from, you create a relationship where somebody will feel comfortable to say, Uzma, well, I'm just with you, can I just mention? And that is freedom to speak rather than necessarily freedom to speak up, but delivers that cultural piece that we're talking about. So maybe we should set that as one of our actions into the culture workforce that's properly considered.
Thank you, Robin. I think you make a good point about freedom to speak as opposed to speak up. You know, we're not talking about megaphones. We're talking about people having conversations, regardless of status. Ella, that's a legacy hand, is it? Ella? Is that a legacy hand? Or?
Oh, sorry, it is, yeah. Sorry, I've spoken.
So could we go back then to you, Kim, after a good, rich discussion, I think?
Absolutely. So to wrap it up a little bit, I'll pick up with Joe how we can do, we don't have to do the in-depth assessment, but we can definitely bring one through, as you say, annually. Ella, to your point, we've had 2 board stories. Both have been really, really powerful. They do take a lot of management, but I think as we get more mature, people might feel more secure. And generally, they're people that have been traumatized by using. We've also had some patient experience group where staff have also spoken out, but we'll have a look at how we can, it's something Joe and I talk about a lot, but getting that confidence for people to be able to do it, but it's important because they've been really powerful. We cannot escape, and I know, Ella, you brought up what I was going to bring up, the cultural task and finish group. It isn't just about How do we change our culture? It is about the staff voice. It's about patient and staff safety as well. But you've only got to look at the self-assessment and what we talk about, and it links to what Robin has just said. We have got low management training compliance. And part of the conversation Joe and I have been having is that why people then start to reach out wider, and what more can we do to make freedom to speak up everyday business, where you can naturally, do you know what? It wouldn't even be freedom to speak up. Hey, I'm having a bad day. How are you? And someone's already down a corridor. So how do we make this absolutely not just a board responsibility that we're role modelling, that it's every day? And I think that will be part of the work that we can build in the Safe and Compassionate Cultural Leadership Programme. Thank you.
Thank you very much, Kim. And thank you, Joe, for everything you're doing as well in role modelling all of this. There's clearly a disconnect between the board and what we're saying and what's happening on the ground, because the staff survey, the CQC report, the other reports we've considered today are all telling us that. So we're going to need to redouble our efforts. And I hope the things that Steve in particular and other senior executives have said today will encourage and empower people to speak freely. So are there any final comments? If not, we do need to approve the self-assessment FSUG reflection and planning tool. If those who compile it feel it's appropriate, it might be worth including the championship of the chair and chief executive, and indeed the whole board, for this agenda as part of the reflective tool. Okay, thank you all very much, and thank you, Joe, for taking the time to join us.
Thanks all. Thank you.
So we move on then to item 12, the Audit and Risk Assurance Committee report, and the matters escalated from that committee. Adam Broom.
Thank you, David. This is the assurance report for Audit and Risk Assurance Committee for May 25, so a while ago now. So it's in the old style. We didn't have time to catch up with the new style, but obviously future reports will be in the new style that you've seen in the other committee assurance reports. In a moment, Lindsay will take us through the board assurance framework report that we've got in our pack, but obviously we consider that at each and every Audit and Risk Assurance Committee. In terms of the May meeting, there was one item brought to the attention of board, please, which was proposed changes to standing orders, standing financial instructions, scheme of delegation, and matters reserved for the board, which we carefully considered at the May meeting in terms of proposed changes to that to reflect, I guess, the new environment we're operating in as a trust, to make sure that we've got fit for purpose, speedy decision making, fit for purpose delegation to appropriate levels in the organisation. That was actually approved at the private board meeting in June, but it's in our papers today, so just for clarity. The focus, other than that, for the May 25 meeting was probably looking at financial year 24-25 and end of year audit arrangements from both external audit and internal audit. So the meeting considered the draft annual report, considered the draft head of internal audit opinion, considered the draft unaudited annual accounts, and an update on the audit from our external audit colleagues. We've subsequently had a special Audit and Risk Assurance Committee and a special board meeting only last week, I think, to consider the outcome from the external audit, which will now then get reported to the public board meeting in September. But in summary, the critical thing, I guess, to highlight would be that we will know, but for public consumption, would be that the accounts had an unqualified opinion, which is the best opinion you can get on a statement of accounts. So that confirmed our financial position for 24-25 as a slight underspend. And I will probably stop there, Chair.
Very much, Adam. Any questions or comments for Adam? So we've already approved the matter that was escalated for transparency. So I think we just have to note the report from the May 2025 meeting of the Audit and Risk Assurance Committee. And thank you very much, Adam. We're very fortunate to have somebody as experienced and thorough as you as our audit chair. So thank you. Could we go on then to 12.1, the Board Assurance Framework? Lindsay.
Thank you, Chair. So the Board Assurance Framework is presented. Colleagues will be aware that the BAF is updated following discussion with executive leads and through the relevant committee meetings. The last time the BAF was reviewed was at its May meeting. There was a key action from an internal audit we had recently with regards to the alignment of our audit committees with our trust board, and just to give assurance to our colleagues that we have now taken that learning and we have proposed new dates for Audit and Risk Assurance Committee so they better align with the trust board meeting. The report is quite self-explanatory, and the changes are made in tracked changes for ease. However, just to draw out the key updates relate to assurances on the actions being taken to improve gaps in assurance relating to urgent and emergency care, our stroke performance and our fracture neck oedema, all of which we've talked heavily about today, and our priorities through our Quality Assurance Committee. Updates on the actions that support our organisational development and our drive towards improvements around our culture, which was subject to a recent board discussion. And as outlined today, there's a task and finish group in development. The report recognises, the BAF recognises the current environment we're working in, and in relation to our obviously ICP cluster arrangements and the focus on the way that we our change management, which links to our culture piece, and our delivery of our transformational change. So that relates to BAF element 3. Just a couple of more points. The updates reflect the mitigating actions to ensure that we have the grip and control on our financial position, and the delivery of our cost improvement plans. Again, that's been highlighted through the meeting today. We've recognised in BAF element 5, which relates to our digital and cyber risk, we've actually increased the likelihood and consequence of cyber risk. We've increased the score. Lastly, in our estates programme, we are in discussion around our estate strategy and the master plan, which is being developed, which will then support our overall organisational strategy refresh. The board had a conversation back in June with regards to our risk appetite, had a really good discussion, and there's a small working group that are going to further establish some recommendations to the board around our risk appetite statement. The report outlines the foreclosures within its resolution. Chair, won't go through those, but I'm happy to take any questions. Thank you.
Thank you very much, Lindsay. Questions or comments for Lindsay? If not, then can I thank you for that update? And I guess we should just note what you've said alongside the paper. Thank you. So that takes us on to item 15, I think, Remuneration and Appointments Committee. So could I go over to you, please, Isabel?
Indeed, thank you. And this will be very swift because the nature of the Remunerations Committee is that a lot of the items that we discuss are very confidential and so therefore aren't shared within this forum. But there's a few key agenda items that we did consider that we can share. One is the ongoing update on the recruitment and appointment of the Chief Medical Officer post. A consideration also, we agreed to do a review of the dual director roles that we share across between Royal Cornwall's Hospital and Cornwall Partnership Foundation Trust. So we'll be undertaking that review later on. We improved the inclusion of non-statutory, non-voting VSMs within scope for the recent MARS scheme, the mutually agreed resignation scheme. We also received and noted an assurance report around out-of-court settlements. And finally, I think just to share that we noted the non-executive director succession and development plan for 25 and 26. So I think I'll leave it there, Chair. Thank you.
Thank you very much, Isabel. Any questions or comments? Given the nature of the work, all the non-executive directors, or nearly all, apart from the chair of audit and members of the committee. So the non-executives have been through this quite thoroughly. Could we note the items considered by Remuneration and Appointments Committee at its May 2025 meetings and the decisions taken on behalf of the board as per the committee's terms of reference. Board content? Thank you. Takes us on to item 14, the integrated performance report. Some of this we've already considered, for example, around urgent and emergency care and fractured neck of femur, stroke, mortality, and so on. But Robin, could I go over to you?
Thank you, David. So as you say, both FP, Finance Performance Committee and Quality Assurance Committee have reviewed the integrated performance report, and we discussed a number of issues throughout this meeting. I would draw colleagues' attention to something that we didn't include in the urgent care report, which is we are seeing a positive impact on length of stay, which is as a result of the actions that we're taking through our clinical vision of flow. From a performance perspective, I'd also draw colleagues' attention to we're still not quite over the line with no longer having patients over 65 weeks on our elective programme. I've defined them as sticky issues that we're still working our way through. They're very low numbers, but tricky to get fixed. And that's despite the fact that we're still seeing progress overall in our elective performance, but slowed slightly. We're taking some further reviews across outpatients, and the information is shared from getting it right first time, so known as GIRFT. Our cancer performance, we've spoken previously, but for colleagues, just to maintain the transparency and the focus on it, is we have some dedicated work within our breast pathway with our radiology and breast teams coming together to find a resolution to the wait for first appointments for our breast patients. And we believe that once that work is concluded, we will see our breast performance recover, and that will bring our overall trust cancer standards back up into although still meeting the national requirements, will be back up into the standard that we aspire to as an organisation. And Chair, from a performance perspective, I would pause there, and I think I'd check with Mary and Kim if there's anything on the quality section that's not been covered.
Mary or Kim?
I think the only thing I'd draw people's attention to is the improved work being done on duty of candour. So whilst 67%, and we should be 100% performance, 67% is across all 4 domains, and that's really important. We've still got some work to do, but we acknowledge that the 33% are the more complex end or the multi-agency end. So we're working really hard with clinical colleagues to be able to draw those to a conclusion. Whilst falls continue to decrease, and we've seen some of that work, such as decaffeinated drinks, for example, we were really concerned as a professional group that pressure ulcers had doubled in May, and the largest increase we've seen is in our urgent and emergency and our acute medical wards. So the senior team are doing a review, and that review will be available in the mid-July, and of course that will go through QAC. We're just trying to see, and just remember, even if you self-present, that still shows up as pressure ulcer damage. In my role as dual, I'd also like to work then with system partners to see what we can do on the prevention end, not just treating the end result. So I'll bring that back through Quality Assurance Committee. Thank you.
Thank you, Kim. Mary?
I think, to be honest, we've covered the things that I would have drawn out from the report in terms of stroke, fractured neck of femur, and also the work that both Steve and Robin have alluded to around the urgent and emergency care challenges. So I don't really have anything to add.
Thank you, Mary. And in relation to the financial and supported and valued people aspects, we've probably covered those off as well. Ian, Alison? Good. Okay then. Any comments or questions for any of the executives on the integrated performance report? Okay, so I think we need to note it for assurance, Lindsay, under the domains of safe, high quality care, supported and valued people, and journey of improvement, which covers finance. Thank you. Now we magically turn ourselves into being a corporate trustee, I think, Lindsay. So we're not a board of directors anymore, we're a corporate trustee, to consider the Charitable Funds Committee Assurance Report. And I'll hand over to the chair of the committee, Richard Kramer.
Great, thank you, David. There's lots to note. One recommendation. So to note, the charities increased their income despite challenging circumstances. Legacy income has been unprecedented, with over 2 million for last year, an additional gift of 600,000 in our first quarter this year, as we've been left a property in the will. We had a really great story around the impact of funding for the maternity team staff room upgrades. It's difficult to track, but we're clear that upgrading the physical environment can improve staff and patient wellbeing. We've launched our Elevate funding rounds, where care groups have been invited to submit one application per care group from between 25k to 50k. I wanted to say that we also approved the purchase of an ultrasound system, and it was really great that the resident doctor, Bothwell, who put together the application, came to the committee to seek approval alongside Dr. David Tucker. I think it's really good that we give resident doctors that platform to put together requests of funding and present that to our committee. So it was great that was approved. The recommendation we're seeking is regards to the family appeal. If you remember, we've approved the recommendation to purchase and refurbish a property off-site as part of that family appeal. We're looking for to purchase a property up to £1 million, property that has 4 to 6 bedrooms within walking distance of the hospital. That search is very much active, and we would also appoint a third party to manage the property. So we're looking for the Trust Board as corporate trustee to approve a delegation authority to the Chief Finance Officer, dual Chief People Officer, in conjunction with the chair of this committee, to make offers on suitable property and to enter into contracts to enable the purchase of property and enter into contracts to enable operation and maintenance of the property following acceptance of the offer. And the reason why we're doing that is because we're looking to purchase a property in the active housing market, and the teams need that flexibility to act and to negotiate with property consultants and so on. Thank you.
Thank you, Richard. So Richard's clearly set out what we're being asked to do as corporate trustee. Obviously, if anyone has any questions or comments, please do come forward with them. But otherwise, we're asked to approve the delegations and approvals as set out in detail on the paper and highlighted by Richard, so I won't read them all out. Is the corporate trustees happy to do that? Alison?
Yeah, I was just going to sort of come in terms of the next paper here, in terms of the approvals, and just to be clear that we moved away from the original plans because of the escalating estates costs. This does provide us this option with the ability to move quickly and to provide, for patients in a relatively short space of time within the constraints that we've outlined in terms of the project scope. For example, that 10-minute walking distance, a way of providing accommodation for patients and for families. And we know there is a strong business case in terms of the reason why it is still needed within Cornwall. So I just wanted to sort of reinforce that. Thank you.
Well, against that background, is the trustee happy to approve? Thank you very much. And of course, Richard, it's always an opportunity for us to place on record our gratitude to all the people who've made this possible through philanthropic giving. All the people and organisations that support us through philanthropic giving and charitable support. Thank you very much. Section C are all starred items. Nobody, I think, has asked to discuss any of them, Lindsay. Therefore, they are received and noted. Doesn't mean to say we don't read them, we don't discuss them. I'm sorry, Ian, nobody did.
Just to be clear that one of them is an approval as well. I know we're noting, but there's one that's an approval.
Any approvals are taken as read unless anyone is asked to discuss it.
Thank you, Chair.
So that takes us on to section D, other matters. First one is summary of consideration of risk, item 23, which are really issues which we need to escalate as a result of this meeting. One of them, obviously, is all the issues we've talked about in relation to freedom to speak up and racial discrimination. But Lindsay, have you got a note of others?
Thank you, Chair. Yes, it was definitely around our the issues we talked about around equality, diversity and inclusion and our pay gap, etc. So I think that's really important. We'll reflect that on our board assurance framework. I think the matters that we've heavily talked about are matters that are already listed on our board assurance framework. I think there's probably more that we can do to articulate the actions that are ongoing. And we've noted today, particularly around our financial position and obviously the pay award clarity, which Ian has articulated, so therefore we can update the board assurance framework with regards to that. But UEC remains a challenge, our pressure ulcers position and our falls and the interrelationships with our NECA-FEMA challenges, our stroke performance and the Royal College review, and we're due our stroke action plan at our next Quality Assurance Committee, which will give some further assurances. And I think otherwise than that, occupational health we've talked about again, and put to, as you've just mentioned, the Chair. So I think we're providing assurance through our committee meetings and our board on the actions that we're taking, and we just need to make sure that's reflected on our board assurance framework.
Okay, Lindsay. Any board members want to raise any other issues in terms of our risk profile? Adam.
I haven't had the opportunity to absolutely definitively check where it's at, either in the board assurance framework or the corporate risk register, but we've touched on artificial intelligence, the growing opportunity and the growing risk, it feels like, around artificial intelligence and how we're governing that without constraining innovation. Feels like it'd be worth another look. Apologies if I've missed it, Lindsay. Okay, thank you.
Kevin wants to comment.
I could say something very briefly,
yes,
just to reassure people. So there are a set of processes in place that apply to AI in the same way as any clinical system. We use those processes and have done for some time. In fact, we're just putting in place a trial for AI and had a vote of confidence from our NHSC regional colleagues in the way that we're approaching that trial, utilising safety documentation that actually supports the process.
AI feels like a deep dive at a private board meeting at some point if ChatGPT tells us that's all right. Alison.
Yeah, I just wondered whether we'd drawn out in the meeting from an information governance perspective enough around the risks on our subject access request and the backlog that we have there. So I just, in terms of risk, want to make sure that we haven't got that sort of within our consideration of risk at the end of the meeting. Thank you.
As I said, I believe it's a corporate risk register on the corporate risk register, but again, we can reflect that conversation, Alison, in our next BAF review.
Thank you. Anything from you, Steve?
No, nothing further.
All right, then, well, having noted those summary considerations of risk, could we move on to a very important item, questions from the public? Lindsay.
Thank you, Chair. We have no questions to pose to the board today. We did have a comment from a colleague internally with regards to some pay matters that relate to them personally, which we will address outside of the meeting. I have written them to them today to confirm that we will liaise with them outside of the meeting, but no matters that are relevant to this agenda of the board.
Thank you, Lindsay. Good to know we've got a satisfied public.
We've had about 42 people watching today.
Well, very pleased that you could join us. So item 25 is a bit of navel gazing for us, but an important piece of process where we just reflect back on the meeting and evaluate what went well and what we think we could improve. Is there any feedback? Adrian.
And I thought the new layout of the agenda and the new reporting from the committees worked very well. There was a nice flow to the meeting.
Glad you felt that. Robin.
Yeah, a number of questions from the public from our board meetings, and I've just been challenging myself. Is there a reduction in questions because our papers are such that they're answering all the questions, or is there something else? And is there a way we can understand if the question drop off is a positive drop off or a negative drop off, if that makes sense as a question to us?
There aren't people fuming out there thinking, oh, I wish I could ask a question.
I could suggest we have in the past undertaken a short survey for our members of the public. So it might be that we could issue a short survey on the back of the Q&A chat here, Chair, for people to comment on and suggest if they are finding that the information is being provided is actually meaning that their questions have been answered.
Great. Yeah.
Thank you.
Yeah. Any way of reaching out to the public would be very helpful. I've got Ella and then Isabel.
Yeah, I think having the BAF and the IPR at the end continues to work well for me as a bit of a sense check around, are we covering in the meeting our key points where we need assurance, and equally are we discussing our key kind of metrics where performance is dropping off. So kind of whilst we don't give them a lot of discussion, it does do the job of a check back around always focusing on the right things during the meeting.
Agree with that, Isabel?
Yeah, no, I think it's been a really good meeting this morning, excellently chaired, if I may say so, Chair, as I'm sat next to you. But I think I just wanted to pick up on Robin's point, because for me, I think if there's anything that we can do to encourage engagement from our patients and communities in Cornwall, you know, these are your services that we're providing. It'd be great actually to get, you know, I'd like to see a situation where we have too many questions that we can't possibly cover in the time that we've got. So if there are other ways that we can do it other than surveying, and encouraging people to engage with us, because this is the only forum really where they have that opportunity publicly to raise concerns or raise questions or encourage us in some way. You know, it could all be very positive, but I'd love to see more engagement from the public and from our staff as well.
Again, a good point. We need to consider that offline, perhaps. Maybe with you as well, Isabel. Are there any other comments? It's always very useful to get that feedback, Ian.
Yeah, so really good meeting. Really enjoyed it. Like the reports, echo that comment in terms of the new structure of the committee reports. We had some good elements in it felt today on equality, diversity and inclusion. I'd still challenge us, are we seeing enough in terms of health inequalities in what we're bringing forward? So when we talk about increases in pressure ulcers, we've talked about our sustained underperformance on fractured neck femur and stroke, but I'm not sure we're doing enough about where is that in our society coming from, and particularly in the mind of the 10-year plan and care in communities, how are we using our knowledge and our data and intelligence to feed into that and to support primary care and other parts of our health system to provide improvements to that point of prevention. So I think there's probably something for us to reflect on about whether there's still more we can do in those areas.
Yeah, I think that's a hole in one, Ian. And with the new ICB cluster, it's something we have to think about as a whole system, I think, because it's, you know, access to primary care, local authority facilities, and there's a whole range of issues that contribute to health inequality. And there's a good report from the Chief Medical Officer on deprivation in coastal and rural communities as well, which perhaps we ought to revisit at some point. So thank you all very much for that feedback, which we'll capture and certainly think about. In terms of our next meeting, just find the right page. Our next, well, we have the trust board in private after this meeting, and then our next public board will be when now in September, 5th of September. So I'm not going to make the mistake of wishing everyone good holidays, because we have summer pressures as well as winter pressures at the Royal Cornwall hospitals. But I know some members will be going off on a well-deserved break, not least our Chief Executive, who will be on a health study tour to Australia. So for those of you who are managing to get a break, I hope you really enjoy it. Can I just thank you? It seems an appropriate point to thank you for all your work during the current year, and look forward to seeing you all again in August and September. So thank you very much. I declare the meeting closed.
Thank you, David.